Welcome to today's Adult Social Care and Community Scrutiny meeting. We've got a full agenda, full of interest as well. First of all, do we have any apologies for absence? I don't think we do we, Joe?
Formal apologies for absence, Chairman, no.
Nope. The minutes of the last meeting held on the 8th of September. Could I just refer you to point 422 on the minutes and ask Sarah if she would, I believe she has a short update to make to us about those minutes. Sarah?
Thank you, Chair. So following our last meeting, we've done some further work on visiting on care homes. And as you may recall, since early July, the Director of Public Health in each local authority is required to have an opinion about whether care home visiting should go ahead or not, based on the rate of infections and a number of other factors. So this is a recommendation to care home managers who make the ultimate decision. So up from early July, when our levels of very low, the recommendation from me was that care home visiting could restart. We changed that recommendation a few weeks ago in light of rising numbers of cases in care home staff and residents. And this received some I suppose, a backlash would be the best way to describe it, I think. There's a real balance struck between balancing the risk of infection to the vulnerable residents in our care homes and the loneliness and isolation they feel have their regular visitors and the impact that has on their total physical and mental well-being. And I think what I would reflect is that there are no easy choices, and the decision to recommend stopping care home visiting was not one that was made lightly. And I do really feel for the families and the residents that haven't been able to have a visit. So I am still really mindful that the cases of COVID in our care home staff and care home residents are rising. So we've got cases in 90 staff at the moment and 64 residents in 13 different care homes. So it's going up every week. We did see a disproportionate number of deaths in our care homes in the first wave, but we've had some really helpful guidance from the Association of Directors of Adult Social Services, known as ADAS, and we've had some further guidance from the Department of Health and Social Care. The work we started to produce some local guidance for care homes to allow COVID-safe visiting was then revised in light of the ADAS and Department of Health and Social Care guidance. We've since shared that with our Gloucestershire Care Providers Association for their comment, and our other sort of main supplier of care homes, Order of St John. We've amended it in light of their feedback, and that will be issued to care homes today. And there is a webinar giving some training to care home managers this afternoon with Gloucestershire Care Providers Association. So once the care homes have taken on board this guidance, it's more of a toolkit really, because the guidance is, but this gives the care homes the tools to implement it. And then the care homes will be able to make the decision about how they want care home visiting to commence. And that's all I wanted to say, Chair.
Thank you. Do you want to say something, Ian?
Yes, I do. I really welcome this. Thank you, Sarah, for that update. But Sarah, it's also been proposed that there should be a system of key visitors so that people can be visited by one person from their family who has had regular testing and is trained in PHE and trained in safety in general, as a way of keeping people in touch. I just wondered, since you're talking about this very subject, whether we in Gloucestershire are considering adopting this proposal to have a key contact, a key visitor who would stay in touch with people in care homes and could, in fact, visit every week or more frequently if they were known to be safe and trained and have the PHE. What's your reaction to that, please? To you, Sarah.
Sorry, I was on mute. Thanks, Ian. Sorry, Ian. So the Department of Health and Social Care guidance didn't specifically mention this concept of essential family care. We mentioned it in our guidance. One of the issues is there's no provision nationally for the regular testing of care home visitors. So there are a couple of pilots we're aware of. So that makes it quite difficult. So whilst I think the guidance provides the tools for the care homes to risk assess who's coming into their homes and how and when to provide PPE and some practical guidance on how to implement it in their care homes. What we're not able to do at the moment is identify how to get that weekly testing for essential family carers. Now, we're told that might be coming soon, but at the moment we don't have a means to do that. So, but I think that there's still not a way for families to visit their relatives regularly by using the guidance we're issuing today. But it's difficult to formally adopt the essential family carers principle because we can't comply with the testing requirement.
Margaret?
Well, just to add, there are some homes in Gloucestershire that have adopted the essential family carers model, which was approved by the Department of Health in July, I think, without, as Sarah quite rightly says, without considering the fact that there isn't a means to test them, and they must be able to show a negative test within the week before. So some homes have found ways around that, which probably is best not discussed, and other people have done them privately. So we're hoping that we will get a move with the pilots that Sarah refers to be able to test people more regularly. But hopefully there are some homes that are able to adopt it. But we have included it, as Sarah says, in our guidance because we think it's really important. It's been well proven to be good for people's both physical and mental well-being.
Well, since we agree it's such a good idea, couldn't we just do this locally in Gloucestershire without waiting for the national guidance?
There isn't any provision of testing though, Ian. I don't have any testing capacity to call upon to facilitate this. That's the problem. I don't have any call on that testing. It is driven by Department of Health and Social Care. We have looked into it. We've actually applied to be a pilot for some rapid testing technologies that you might have seen on the news to be able to support care home visiting, and we're waiting to hear the outcome of that application. But at the moment, I don't have any tests at my disposal. And bearing in mind we have 6,000 care home beds, that potentially could be an awful lot of essential family carers that would need weekly testing. So it's not a small undertaking. That's the issue. There's a huge logistical challenge to this, which is why it needs a national testing programme.
We'll have to wait, won't we? We will. Can I now proceed on to do we have any declarations of interest? No, that's good. We then move on to, would you believe it, Sarah's annual report. Sarah. We also have a slideshow.
Yes, so we've got some slides that Andrew will just put up for us now. She'll share her screen, but I'd like to introduce Althea Lynn. Althea is a commissioning officer in GCC, but is also co-chair of the Black Workers Network. And we were originally planning to write our annual report this year on domestic abuse. And this is a really, really important subject for our communities. But when we had initially thought we might postpone the annual report because of capacity issues in the team. But I think what we learned throughout the first wave about the inequalities of around COVID and its impact on particular ethnic groups really prompted us to try and find some additional capacity to write a report on race and ethnicity and COVID. So what you've got before you today is a report that we've co-authored with our Black Workers Network in GCC. I'm really proud of it. I think, as always, our Director of Public Health reports always focus on an aspect of inequalities. This year it's on race, health and inequality. And what we'll do, Alfie and I will just talk you through this brief presentation, and then I'm hoping there'll be time for questions afterwards. So if I could have the first slide, please. So the report focuses, as I said, on the impact of the COVID pandemic on BAME communities, and also reflects on what we've learned so far through the Black Lives Matter social movement. We also draw upon a really important piece of research carried out by Public Health England that was published in June called Beyond the Data, Understanding the Impact of COVID on Black, Asian and minority ethnic groups. And that was really one of the turning points in the pandemic for this piece of work, because it really highlighted some of the impacts that our BAME communities have experienced. And it also seeks to highlight some of the inequalities, but also focus on some of the positive stories that we've uncovered in our BAME communities in Gloucestershire. So you've heard me talk about inequalities before. These are unfair and unavoidable differences in people's health across our population. And the diagram there gives you an overview. I'm conscious of time, and I'm sure you've all read the report, so I'll just go through these slides. If I could have the next one, please, Andrea. In the report, we also look at three main areas of inequality: education, housing, and employment, and present some quite stark data around the impact of on education for some of our Black peoples in particular who don't fare as well as other ethnic groups. We also look at housing, and we know that people from a Black, Asian, and minority ethnic background are more likely to live in poor quality housing. It's overcrowded than white British people. And we also look at unemployment, and unemployment is particularly topical at the moment because we know that the unemployment levels are rising, and that BAME adults, particularly the younger adults, are more likely to be unemployed than white British adults of the same age. So just trying to tease out some of those inequalities to really help us think through our recommendations. So on the next slide, please, Andrea, we talk about the risk of developing COVID. And there's been quite a lot of data produced nationally about this. We haven't got so much at a local level, but what we do know that belonging to certain ethnic groups increases the likelihood of contracting COVID-19 and developing severe symptoms and dying from the virus. Asian, Black and white other ethnic groups are overrepresented in the positive COVID-19 cases compared to their country's broader population. And I think what we're now seeing through the national data is that Black and Asian people are between 2.5 and 3 times more likely to be admitted to hospital with COVID than white people of the same age. That's a massive inequality. And nationally, we know that people of Bangladeshi ethnicity had around twice the risk of death than other people of white British, of similar ages of white British ethnicity, and that people of Chinese, Indian, other Asian, Caribbean and Black ethnicity have between 10 and 50% higher risk of death when compared to white British. So these are quite stark statistics. This is a risk of dying through an infectious disease that we're all trying desperately to avoid. So I think the pandemic has really shown how important it is to gain really good comprehensive data on inequalities. And we've really struggled at times to find really accurate data on ethnicity. And this includes a death registration. So the next slide tries to focus a bit more on some of the positive aspects of COVID. And we've seen some brilliant, we know the community sector is really vibrant in Gloucestershire, but some really good examples of where communities have come together to help each other. And this is the quote from Imran Atcher at the Friendship Cafe in Barton and Treadworth. And they organised the street rec scheme. They made thousands and thousands of meals for their community over wave one and really came together to help their community. So there were some really good examples of support. But essentially, we are looking at some serious inequalities. The next slide talks about employment being a key risk factor, and we know that we see a disproportionate amount of BAME people in frontline jobs, in lower paid jobs. So we saw security guards, porters, cleaning staff in hospitals, healthcare assistants, nurses, doctors, these people who are on the front line and having a disproportionate impact in terms of COVID cases and deaths. And there's some quotes there from some BAME employees in the public sector in Gloucestershire, just trying to outline their experiences of trying to navigate the complexity around how to do a risk assessment because of their ethnic background against COVID. And this came very quickly to us to do. And I think it highlights some of the worry and the uncertainty that our colleagues have experienced. So we need to be mindful of what we do and make sure that we are supporting our BAME colleagues to have the correct occupational risk assessment and the correct amount of PPE as and when they need it. The next slide talks about how people have heard messages, and I've spent an awful lot of time working with our head of comms to try and understand how our messages around COVID have been heard by our businesses. As well, we've done lots of work with businesses, we've done some work with young people. To ensure people continue to adhere to the guidance because that ultimately will keep them safe. And this particular slide refers to some research done by the Runnymede Trust, and they commissioned a poll of just over 2,500 adults about their experiences during the pandemic and whether they were aware of the health protection or economic measures rolled out by the government. So initially the request by the government to stay home, protect the NHS and save lives, which then became stay alert, control the virus, save lives. But but also the fact you could get mandatory sick pay from the first day of self-isolation, and that we had a furlough scheme where you could get up to 80% of your wages if you're unable to work during the crisis. And this showed a really worrying trend in that depending on your ethnic group, there was a real difference in whether you understood and heard these messages. So you can see there the Bangladeshi community, just 61% of the sample actually said that they heard and understood the messages. And it also revealed some real barriers to communication in terms of an assumption that everyone has access to digital communication. There was issues around cultural insensitivity and a fear and a mistrust of the government as well. So we're really using that now in terms of how we move forward with some of our messaging in Gloucestershire to make sure that it is culturally appropriate, because we know that the control measures of washing your hands, wearing a face mask, social distancing and testing where appropriate, then self-isolating do work. But we need to make sure that message is understood by everybody. On my last slide, before I hand over to Althea, talks about pre-existing conditions. So as I said, we know that some ethnic groups are more predisposed to contracting COVID and then having more severe complications. And we also know, for example, some South Asian communities are more predisposed to things like diabetes. So diabetes was mentioned on 21% of the death certificates. So there's a correlation between having diabetes and being overweight and having complications with COVID. But what it seems to suggest is that the BAME communities are more predisposed to this, so therefore their diabetes doesn't have to be as severe as it would be in a white person of a similar age, and they don't have to be as overweight as a white person of a similar age. They're more likely to catch COVID and get some complications. So what we really must do is continue to try and make sure that where we're commissioning or planning health improvement interventions, and there's an example from We Can Move in the report, and another example from our Healthy Lifestyle Service, that we're really working with the community we want to target and co-produce that intervention to make sure it's relevant and it's understood and it's culturally appropriate. Because if we don't, then there's not going to be any traction and the whole thing will be a bit of a waste of time. So that was a really important point for us, I think, throughout this report. So I'm going to hand over to Althea now. She's going to talk you through the last bit of the report on our recommendations. Althea.
Althea, are you there? Have you got your microphone unmuted?
I used my space bar and it didn't work. Morning, everyone. Sorry about that.
Morning. Good morning.
Good morning. Yeah, my space bar actually didn't work this time. Okay, can you hear me? Can everyone hear me?
Loud and clear.
Brilliant. Okay, just following on from what Sarah's saying, and some of the changes that are required really do require a cultural shift in organisations to be able to implement them effectively. And the slide that talks about becoming a culturally competent organisation is really requiring organisations and individuals to shift. If you look at that continuum, is really to shift from understanding their, one's own experience and the privileges and rights that they have as being part of a dominant group, but also being the decision makers in a dominant group, to understanding how the racism and the stereotypes that pervade continue to disproportionately impact on BME communities, because the decisions that you make are based on one's own experience of life, society, and your workplace. So it's really trying to get people to really think about what the differences are, not treat everyone the same, because that's where, if you treat everyone the same, we make the same decisions, we have the same outcomes. But starting to shift towards a conversation where you do explore cultural issues, consider the assessed needs of both your organisation, but actually understanding individuals in your organisation and individuals and communities, and start to think about, well, what actually are those differences? The cultural differences, the individual differences, and the diversity between groups, because we're not all homogenous, as you understand. But once you understand what those cultural differences are, it's then about thinking about, well, how do I start to shift that in my organisation? And one of the simple ways of doing that is ensuring that you have system processes in your organisation to actually hire staff that are who have cultural competence, but can demonstrate that they are culturally unbiased in their both not only in their hiring processes, but also in terms of how they function as managers, as colleagues within teams. So it's starting to create an organisation that becomes, looks at unconscious bias and is able to deliver that in a culturally competent way. And some of that will just literally require training. Unconscious bias training is widely available, as is cultural intelligence training. And so it's thinking about using that to ensure the organisation starts to shift along that continuum and to be able to become culturally competent. And finally, it's implementing the changes so that you actually then can see that services are improved, but they are, and the outcomes and those services are improved based upon cultural needs as opposed to the host organisation's needs. So that's how you make a shift. The Black Workers Network is continues to work on these aspects, and so you are able to make contact with us, and we can offer advice. And you can contact us at bwn@gloucestershire.gov.uk if you want to know more about that. Next slide, please, Andrea. Okay, cooperation and co-production then focuses very much on. Sorry, my slide disappeared. So cooperation and co-production, that really is about making sure that when you are identifying needs, that you work with members of the community to understand their lived experience, particularly of discrimination and structural racism, so that they are informing your processes. Without that, you'll be commissioning and services that continue to look like they do now, which will continue to perpetuate the health inequalities. So once you've identified the need by having those conversations at the earliest stage, you plan your intervention and your service, but you go back and do further consultation based on what you've already been told and complete your equality impact assessment. By doing that, you will ensure that you will have those meaningful changes and that there will be service improvement and delivery to marginalised groups, because currently the situation is, because of the discriminatory policies and processes, the unconscious bias amongst staff and the lack of representation of people at all levels of the organisation, there continues to be a detrimental impact on the access, experiences and outcomes of BMA residents in public services. And the feedback we very much received was that residents felt they were done to or consulted with, but then sometimes they didn't actually see the outcomes of their time and the input, which was demoralising, but continue to disenfranchise them. But there is the opportunity to be more consistent and collaborative in our actions to ensure that we work with individuals and communities and recognising their assets that they have to contribute, and they have significant assets and skills, as Sarah's just alluded to. Next slide, please, Andrea. So looking now towards the recommendations, and we drew on these recommendations from the public health review that came out in May of this year. So we tried to make sure that we aligned those, our Gloucestershire recommendations in this report with those recommendations. So what we're thinking is, as Gloucestershire moves out of the response phase of the pandemic, it's even more important to honour and expand on long-standing commitments to tackle the root causes of health inequalities. And as organisations develop their recovery plans, we have a critical opportunity to rethink the approaches of the past that have actually led us to this point, and to instead work in partnership with communities to create long-term sustainable change. So in order to do that, that will involve improved data collection and undertaking research, and reviewing our commissioning processes in practice to ensure that equality impact assessments and BMA service user data and feedback are used in a more meaningful way, so that they do inform future services. So we should be seeing, different types of services commissioned if we take those three aspects into account. Next slide, please. So recommendations 4 to 6. So Sarah's already spoken about the occupational risk assessment tools and how we need to ensure that they are BME COVID specific and take into account those additional risks that BME frontline staff have included as part of their work and life experience, but also it's not because they are BMEs, it's because of the work that they're doing. They are, disproportionately working on the front line. But that's not just in the public sector, that's also in other essential worker roles, people who are driving taxis, people who are working supermarkets, for example. They also are disproportionately impacted. So in order to be able to achieve that, that's about working proactively with the BME and faith community representatives to make sure that we can distribute culturally competent COVID prevention and health promotion communication plans, both at the organisational level and through the local resilience forum and infrastructure. And some work has already started to take place through the BME Task and Finish group, but there is a lot more work that we need to do to ensure that we communicate in a culturally competent way to ensure that we do some of that health promotion and health improvement work. And also then to ensure that the COVID-19 recovery strategies actively reduce the inequalities that are caused by those wider determinants of health. And the Recovery Coordination Group should regularly really review the equality implications within its remit and to ensure that BME staff, residents and other marginalised groups are included in that. And without that inclusion, without that consultation and conversation, again, I can't reiterate more, you will have the same and similar outcomes as we've had in the past. So final slide. Okay, and this is one that actually is very much local to Gloucestershire, but whilst it's local to Gloucestershire, it has to be noted that other counties and districts have a similar issue when it comes to the BME voluntary sector. So very much at the moment, the BME voluntary sector is quite poorly funded. It's reliant very much on volunteers. It has little infrastructure support. And when we had the early stages of lockdown, as Sarah said, the voluntary sector, the BME voluntary sector came together and actually was pretty magnificent in supporting people within communities, providing the meals, getting information out there, providing advice. But it was difficult. It wasn't easy to do. And the voluntary sector organisations are very clear that the lack of an infrastructure support is really inhibiting their ability to provide a similar COVID response as other host community voluntary sector organisations are providing. So one of the things we're saying is we do really need to rethink and seek to build capacity and sustainability much longer term within this sector. And the final recommendation, I believe, yes, the final recommendation was really about thinking about establishing a race equality panel for Gloucestershire, which will then complement the work of the Gloucester City Council Race Equality Commission. That commission is going to run for a year, and at this stage, we don't know what the recommendations for that commission will be. I understand it's going to start in December of this year. But the idea of a race equality panel, the way we saw it was similar to the Learning Disability Partnership Board, similar to the Autism Partnership Board, the Mental Health Partnership Board, to really think about how we can have some oversight and that organisations can buy into a more structured approach to race equality and have some oversight of that. And the point of that was to ensure that we continue the momentum that has started already and to be able to continue the conversations and drive this agenda forward in order to create that long-term sustainable change. Thank you very much.
Thank you, Althea. Sarah, do we want to be asking some questions at this point?
We'd welcome any questions that people would like to ask.
Does anyone have any questions for Sarah and Althea? Brian.
Thank you. Yeah, very, very interesting presentation and a lot to sort of take in, particularly on the longer term changes, which we need to take on board to get a better handle on some of this going forward. But a lot of those steps were long term. So I was just interested in teasing out a little bit from the experience we've had. So it looks like, at the start of the COVID crisis, we were ineffective in quite a few ways because we didn't understand the virus and didn't know why. So there are whole sort of groups as well as the BME, such as older people. We did seem to sort of identify that shielding was important for them. So I think we sort of guessed that one early on. But we were struggling with PPE in the early days. And it looks like more PPE for some of those people in those jobs that were high risk, such as taxi driving and such like, would have been helpful, or maybe some changes to the work. And I'm just wondering whether, looking back on that, were we slow in understanding the additional risks to this group, and why do you think that would have been? And my second question really is about what we're doing now, because clearly listening to the recommendations that need to come forward, which all make a lot of sense, we are in a crisis at the present time, and we've identified now that this group has some additional risks. What are we doing additionally to make sure that we are taking immediate steps to try and reduce the impact, or to reduce the risk in this group? Thank you.
Thanks, Brian. Who's the one?
I start, and then I can.
Okay, Sarah.
I think the question was, were we slow responding? This was a new disease, and we had no idea back in February when we had our first 2 cases that this would have a disproportionate impact on BAME members of our community. We just didn't know that. And I don't think it was, there was some early evidence coming out throughout the spring, but it wasn't really until the report, the PHE report, that brought that all together, I think, that we were really aware. There was certainly a lot of guidance for health and care organisations in terms of risk assessments and understanding how we protect those that were exposed to COVID through the course of their work in health and care. I can't comment in terms of specifics about taxi drivers. A lot of that is about workplace risk assessment and looking at the vulnerabilities of your staff. We did, as a country, struggle with PPE, but as I've said before to this committee, we didn't ever run out of PPE in Gloucestershire, and we had a fantastic health and care system response to PPE where we worked together. And no one, to the best of my knowledge, no one ever ran out. They might have come within 24 hours of the last of their stock, but we always managed to get them some stock to ensure that they had what they needed. In terms of what we're doing now, I think there's been a huge amount of guidance.
Can I just come back on that first point before you go on to the second one? When you say we had plenty of PPE, what we didn't appear to be doing was giving it to taxi drivers and doormen, when they should have obviously been using it just like anybody else in the high-risk groups. And that was my point about, were we slow in identifying for that group when we clearly understood it for some other groups?
We're not giving it to taxi drivers and doormen now. We were given PPE for the health and care system and for frontline workers in the statutory sector. Possibly, but I don't know that we have the supplies to give to provide to the private sector as well. I don't know whether we need to think that through, but at the moment we've now got different supply routes that have become slightly more embedded and systematic rather than having large PPE drops to the local resilience forum. But no, we didn't give to taxi drivers, and I don't think we gave to doormen either, and other sort of frontline security staff, that sort of thing. And we're not doing that now. But I think now that the supply chains are more established, it's primarily for the employers to provide the PPE. Now the supply chains are a bit more back on track.
Hi. So yeah. Oh, sorry, Sarah. You continue, are you? Sorry.
Go ahead. You go ahead, Althea. It's fine.
Yeah. It was just in reference to were we slow, and I think actually, and I can echo Sarah's point, is that there wasn't sufficient information around. You had some headlines around BMEs, in the national press and media to say that there was potentially this disproportionate impact. What that was and how it played out in the early stages, we weren't clear about locally. We just knew that there was a disproportionate impact. So in the early stages, we were having conversations. The network was having conversations with public health. And there is a BME task and finish group that has been now running for probably since May to start looking at some of these issues and having those early conversations with those key worker groups. So we've done that sort of culturally competent approach in order to communicate with the potentially affected groups at the early stage, to look at the risk assessment process, for example. And once we received the public health review, that then outlined very clearly some of the messages and the recommendations, we were in a position then to start thinking, more strategically about what we needed to do. So that, from my perspective, that's how it's worked in Gloucestershire.
Okay, thank you. The second point was really about, are we doing enough now? I don't know who wanted to pick that up.
Sarah?
I can certainly start. So I think that there's been some very, very specific guidance, certainly for the health and care system, around how we protect our own staff, and the risk assessments that need to happen, and then the action needs to be taken. I think the quotes you see in the presentation indicate that perhaps we haven't got that right first time. But I think work is ongoing. As Alfie has said, there's the COVID BME task group in GCC. There is a huge amount of work going on across the NHS locally, and this is a key focus of the integrated care system at the moment. We're trying to ensure that we protect BAME staff as much as possible in wave 2 and going forward. I think there probably might be a gap around the more general population in terms of, as you said, Brian, the taxi drivers and frontline staff that perhaps aren't in a statutory sector organisation. It's also looking at this as well, and that may be where there is a gap.
Yeah, so the BME task and finish. Can you hear me now? Because mine says I'm not on mute.
We can hear you.
Yep. Okay. Good. Yeah. So certainly the BME Task and Finish group has made links with taxi organisations and started to have those conversations about PPE. And what we're finding, actually, whilst it's not being provided through the local resilience fund, they certainly are making use of PPE and ensuring that they are protected as they're out there doing their work. The BMA Task and Finish group is also working with the local community organisations to develop an information, and in fact the information portal has been developed. So there are a lot of resources on the GCC website that points community organisations and individuals to culturally appropriate resources, but also explains COVID and the prevention measures, the health promotion, explains that all in a culturally competent way. In addition to this, we're also starting to look at how we develop trusted community individuals to take information out during the second wave and ensure that people are taking the necessary precautions. They do understand what they need to do in this second wave, but also talking to them about uptake of the vaccine when that's available, and also talk to them about the uptake of flu vaccine, which is equally important. One of the things that's important to mention, and I think when we looked at it came up in the risk assessment slide, is that a lot of it was more about mistrust as opposed to the availability of a risk assessment, and that is a huge issue for the BME community. It's the mistrust in a long-standing mistrust in health and services, mistrust not just when it comes to vaccine and accessing flu jabs, for example, or the potential COVID vaccine, but a lack of trust in health services because of previous experiences. So a lot of work that the BMA Task and Finish group is doing is to try to dispel those myths, try to break down the barriers, try to bring the BME community closer to the health services and the health prevention services that are available. So we're at the beginning stage of that. We've got a long way to go because it is about breaking down the barriers. So there's sort of a twofold response, really, the direct public health response, but equally a culturally competent response that is supported by public health and the BME Task Finish group to break down the barriers that exist between the BME community and our health and social care services. So that's where we're at. And in terms of the risk assessment, the individual public organisations have adapted their risk assessments at an early stage. And the work that the Task and Finish group has been doing is to review those risk assessment processes and support those organisations to make sure that they're culturally competent, but also the way they communicate the needs for those assessments to their staff and break down some of the barriers and dispel the myths is what our role has been.
Thank you.
Thank you. Very, very helpful.
It's just a question, really. Is it possible for us to use our BME staff in health services to reach out to their local communities to try and get them to understand the role that they play? Because they're very well represented amongst the staff at all clinical levels and indeed at other roles within the health service. And I just wonder, have we got an untapped resource there that we're not making the most of?
That's a good point, Margaret, and one maybe we could ask the COVID task group to have a look at, and whether we could use them as champions or the conduits for information and feedback back to us. I don't know what you think, Althea.
Yes, currently some of the community development team are instrumental in doing some of that work at the moment. We're using them as a resource. They're using the Black Workers Network as a resource to communicate more broadly and widely out to communities. And certainly within health, I mean, you've got an untapped resource there. Most definitely. I think the thing to bear in mind is that whether it's COVID or, you know, we have a third wave or it's another pandemic, that there needs to be the infrastructure built in behind it to ensure that longer term, should we have something else happening, people are ready to run with it as opposed to reacting. It's we need to make it more sustainable. And embedded within any organisation's culture, that it's there and it's available, and it's a business as usual thing in the longer term.
Okay, thank you. Any more questions? Tim, and then Ian.
It's not a question as such, or there is a question in it, Chairman, but I'd just like to add my thanks to those of Sarah in the foreword, who refers to the work of the public health team in bringing this very important report forward. I think we should all support that, because obviously it has been an exceptional few months, and to bring this important report forward with everything else going on has been really good. And I'd also like to say, perhaps ask Sarah to confirm, that in the past, Sarah, it's been your practice to present this report, or to make the offer to present the report to the district councils, because I think their buy-in to this and their support of what we're trying to do is very important.
Thank you, Tim. Ian?
Yes, I'm happy to send it anywhere and to anyone that wants to hear it. Thanks, Tim.
Yeah.
Thank you very much for this important report. I'd just like to ask one primary question and one supplementary to that. The first one is that there's a really important recommendation in this report that good quality ethnicity data collection is made with regard to all GCC services, either directly provided and those that are commissioned. So, and my question, and I'm glad we've got Tim from the Cabinet here, is will this actually be done by the leadership of the County Council? And maybe Sarah could reply to that, or Tim could reply to that. We really need these good quality ethnicity data. And my supplementary to that really is, will the ethnicity data actually be broken down further than it has been to date? We've already heard how the Bangladeshi community has certain issues and certain perspectives, that they're different from the BAME, which is all lumped together. So I think it's really important that we break down, for example, the South Asian community into those with Indian, Pakistan or Bangladesh heritage, or the Black community into those with African or West Indian heritage, because we know that they have different experiences. So that's my supplementary question. But my primary question I go back to is, are we going to act on this really important recommendation? And I would like an answer to that from Sarah or Tim, or both. Thank you.
Thanks, Ian. I'm happy to answer that. This is the first time I presented this report. So we've now got a series of meetings to attend, one of which is the County Council's corporate leadership team, It has been sent to the Cabinet, it's been sent to all district and county leaders, it's been sent to the police, the health service in terms of the chairs and chief execs. It's gone very wide. I've already had quite a number of invitations to present it. But in terms of GCC, it's scheduled to go, I think, at the end of November, beginning of December, to our corporate leadership team meeting. And the primary purpose of that is to share the report, but also to discuss the recommendations, and particularly which of the recommendations we feel we can take forward as an organisation. I mean, you would expect me to say this because public health is a data-driven, evidence-driven function, but we need reliable data. And the issue around good quality ethnicity data is not a new one, but it has really hampered us during the pandemic. So I will be really pushing for GCC to try and support this recommendation, because I think it will help us in the long run. And I think your supplementary point about breaking the ethnicity down is absolutely right. There's no point doing it if we collect it at such a high level. It doesn't tell us what we need. It doesn't give us the right information. So that's the recommendation. It's a recommendation in my report, so I'll be actively supporting that.
Thank you. Do we have any more questions?
Can we have a report back to this committee on what happens when you put these recommendations forward for action?
I'll be very happy to do that, Ian. Sorry, Stephen. Sorry. I was going to suggest that perhaps we come back in 6 months and report back on the progress, because some of these are not necessarily quick wins, and some of them absolutely have to be quick wins to protect people during the pandemic. And would the committee find that acceptable?
I think we will find it very acceptable, Sarah. And if Joe could make a note of that to jog our memories when it comes up to the 6 months.
We can add that to the work plan.
It's on the work plan, yes. Could I ask what may appear to be a simple question? We've all been invaded by some strap lines. One strap line was hands, face, and space. What relevance would those kind of strap lines have to the BME community? Is it equally transferable?
It's. I wouldn't say it's equally transferable. It's how the hands, face, and space is communicated, really, and the relevance for particular BME communities, and not only the relevance, the ability to be able to do some of that, because some people are living in, the report talks about living in the crowded housing, working in particular occupations, but it's trying to enable people to understand how they can effectively interpret the hands, face, and space by ensuring that the approach to communication is culturally competent and directly engages those community, and that's what's key, really. The national messages really are there for the host organisation to interpret as they wish. However, that additional bit of work always needs to take place with BME communities to provide that message in a way that their lived experience can understand and respond to.
And I've got a second comment is, will this problem or opportunity change over the years as school children who are more English than not get older?
When you say, do you mean the communication difficulties?
Yes. Will they diminish as time goes along?
It will diminish, but it depends on how people come into and out and move through immigration systems, for example, because immigration will always be there, and there will always be people who don't have English as a first language, older people currently living in our county who don't have English as a first language. Communication difficulties will change, obviously, when they pass on. However, the cultural competence will always be a requirement. It will always be a requirement on the basis that we're not the whole homogenous group, in the same way that we would need to communicate to our deaf community and sensory impaired community. There will still be a requirement to ensure that we communicate effectively with people from BME backgrounds, because it's about the cultural competence and understanding of their lived experience and the systemic racism that is currently in place, and we hope we'll see that diminish over a period of time, but that's not something that's immediate. So we still need to focus on cultural competence as we go forward.
One more comment. I think Sarah talked about quick wins. Can you give us an example of a quick win in this context?
I think for me, it's about our communication, because we're in the second wave now, and we absolutely have to make sure that all the effort that we put into our communications, that what we think is being sent out is being heard and understood by the communities that we know are most at risk. So as an example, I went to meet the 3 chairs of the committees at our 3 mosques in Gloucester recently to try and make sure that we'll just try and ask them what they needed. And actually they told me they needed leaflets. They didn't want digital resources. They wanted to go and hand them out and put them through letterboxes and have socially distanced chats. So we're facilitating that. We're getting some leaflets printed. We're getting them done in different languages. So that's my quick win, I think, that the messages around how to stay safe in the pandemic are culturally appropriate and are heard by those most at risk. Alfie may have another view as well.
No, I would agree with you, Sarah, and it really is about understanding what the needs of those individuals are in the community and responding effectively. So that goes back to the conversation I had earlier about the early engagement, understanding what they're saying is going to be the best way of communicating and engaging with them, and then responding directly to that. And digital access is definitely an issue for BME communities. And as Sarah said, many will say actually the leaflet works more effectively for us, and the face-to-face conversation is more effective. And so we're focusing on doing more of that and less of trying to get them to engage with us digitally.
Okay, thank you. Any more questions, members? Everybody satisfied? Andrew is waving.
I certainly am waving. It's been a very, very interesting and insightful presentation. I'd like to thank everybody who's contributed. The thought goes through my mind that as elected members, there's one thing that we can all do and should be doing all the time, and that is to make sure that the elected membership of Gloucestershire County Council is much more representative of society as a whole. And instead of talking about what do they want, we ask our colleagues, what do you want? So I think that we should never forget, we all have that responsibility to go out and make the elected membership of Gloucestershire County Council much more representative of Gloucestershire as a whole. Thank you.
Thank you. Okay, thank you very much, members. Sarah, do you want to continue?
No, I've got nothing else to say, thank you. That's a really helpful discussion. Thank you.
Good. Margaret, I think it's your session next, isn't it? Talking about a particular aspect.
Yeah, so just right on cue, I start my session and the dog starts barking.
We saw them running around and jumping up and down.
They do like to be on the camera, I'm afraid. They're a bit attention seeking today. I don't know what's got into them, but anyway. So I've got 3 reports in a row, so I'm really sorry that you're going to get a bit bored. But the first one is the annual safeguarding report, and members will have seen previous years of these. Obviously, this year, as with everything else, is slightly different because we see the start of the impact of COVID on the end of this report. I'm assuming that people have read it. There are some case studies there which try to reflect the different types of work that the safeguarding team do, and obviously the statistics about conversion from referral into actual cases, and what we do when we try to learn from when things go wrong. So the SARS, and there are 3 SARS in this report. We're very fortunate that we only had 3 last year, so that's a good place to be. The safeguarding team has grown substantially over the years and has become much more sophisticated and also much more connected with its regional and national colleagues. So I think that's a good reflection of that in the report. And I would be very happy to take any questions. Just to mention that we only agreed it yesterday, so it's not in the report, but the 3-year strategy that we've got finishes next March. And because of the strange times we're in, we've decided, well, we're going to make a recommendation to the board. We can't decide without the board agreeing it, that we extend that into a 4-year strategy. So we take it to 2022 in order to give us some sustainability and stability over the next 12 months. And then we'll have a new strategy in 2022. Or you will. I won't be here then.
For Margaret?
Sorry?
Any questions for Margaret? Ian?
Thank you. I have 2 questions on the safeguarding report relating to section 5.3, which is the Gloucestershire Hospitals NHS Foundation Trust. My first question is, it says here, risks and issues of note are there's a gap in service provision to patients with complex and multiple conditions as they transition from paediatrics to adult services, which is the root cause of many poor patient experiences, complaints and expressions of safeguarding concerns. So what are we going to do about this? What's the plan to deal with that identified risk and issue? And secondly, further on, it says an increase in the number of allegations has been made against our staff in the early months of 2020, and this has prompted a review and revision of the process managers are to follow when investigating such allegations. I just wondered if you'd like to throw some light on this this statement, which sort of begs questions, really. Those are my 2 questions. Thank you.
Okay, so in terms of the children's services, and you may or may not know, but the Children's Safeguarding Board has changed its format over the last year, and it doesn't have an independent chair and the same format as adults anymore. It has an independent advisor, and that may only be one word that's different, but the practice is different. And it's our view, and again, I only discussed this yesterday with our independent chair, that we think we've drifted apart from the Children's Board over the last 12 to 18 months. And so we want to try and get closer to them again. We used to do a lot of joint training and a lot of joint events. And in fact, at one point shared some staff. And I think we need to get back into doing some of that, but we need to do it in a way that's acceptable to children. So one of my jobs from yesterday's meeting is to take that up with Chris Spencer and to see how might we work differently in the future to try and align some of those purposes, because it is very different. I mean, transition from children to adults in every manner is difficult, but in safeguarding it has particular challenges because of the rights of the individual and the capacity assessment element for an adult. So we're going to do that. In respect of referrals into investigation by staff, this is it's quite interesting. So if you read this alongside the annual complaints report, which we published probably about a month ago, we've had the lowest number of complaints that we've ever had in adult social care in the last year, just 138 in the entire year, all of which were resolved at source. And yet, but what we've noticed is that most of them are about how people talk to each other or how people interact when they are in difficult situations. And it's that balance between taking a professional view and having the right amount of empathy and sympathy and compassion for somebody. And so the complaints that this is referring to is when people take a very hard line about something until it's proven one way or the other. So that's one of the learnings from this report, is taking that back to staff to make sure that they understand that they can be both disciplined and caring at the same time, rather than, trying to. I don't like the word defensive, and I'm hoping that people are not defensive, but it's that moment, isn't it, when somebody thinks that they need to protect somebody, but they may or may not come down on the same side in the end. And I think that's the bit that some staff struggle with.
Thank you. Steve. I think we can't hear you, Steve. You may have to turn your volume up.
That's strange because he's not on mute.
No, he's not. It's a long way to Nailsworth, though.
If we can't hear you, I don't know if you've activated your audio. Can we come back to you while you just see?
Would you want to put it in the chat box, Steve, and I'll pick it up? I wonder if he can hear us.
Can you just try and unmute again?
You can hear us, can't you, Steve?
You are muted now. Do you want to unmute and just try one more time, and then if not, we'll pop you in the chat box.
No good.
Sorry. Pop it into the chat and we'll pick it up later.
Andrea has reminded me that... Hello? Andrea has reminded me that there is on the 26th of November on the 26th of November, there is a meeting to discuss safeguarding children. And that meeting will include representatives from the police and health department, and will also be attended by the independent scrutineer. So that's the 26th of November.
Excellent. Maybe we could pick that up then. That's good.
Yes, yes. Now, where did we get to? Steve was wanting to ask a question, but we couldn't get through to him. No, and he's waved in disgust, so there we are. So, do you want to carry on, Margaret?
Well, it's just if anybody's got any other questions, or I'll move on to my next report, whichever you prefer.
It sounds that may be the best course of action.
Let me go back to my screen then, because I can't do... I've only got one screen, so I can't do two things. Well, I can do two things at once, but one has to be in the dark. Okie dokie. So my second report, this committee asked specifically for last time, which is about the future of the care providers, both care homes and domiciliary care providers in the county, bearing in mind the impact of COVID, but also the business models that we have again in the county. Again, this committee will know, because we've reported it before, that we have too much capacity in the care home industry in the county, with many beds empty at any one time. That's been significantly impacted by COVID, whereby both individuals themselves are choosing not to go into full-time care if they can possibly help it, but also, and they're going to places like extra care housing, supported living, or indeed adjusting their own homes to stay there. And also families have demonstrated that they would prefer to look after their family more than actually having them in homes. We've had a number of people whose family have taken them out of care homes, not a significant number as the South East or inner London, but we have had some. And this has resulted in an even greater capacity. That has its own risks, in that we're trying to predict what we will need for the future. We were always on track, and we have a strategy that went through Cabinet, I think last year, if not the year before, last year I think, to help people to stay in their own homes or different alternatives. And we've got a housing strategy, housing with care, that went through Cabinet earlier this year, to try and develop different types of housing so that people could be more independent for longer. And hopefully this report reflects that. We have about a 20% vacancy rate. Some of our homes have a 40% vacancy rate. One home has a 60% vacancy rate at the moment because of its location and probably its cost. So it is interesting. The other part of the market is that self-funders are now choosing not necessarily to go into care. So we're seeing that. The opposite side of that, of course, is that we've had a huge increase in demand for domiciliary care. If I was good with my computer, I could find the figure. I think, I'll check it for the minutes, but I think in the last month, we've had a 58% increase in demand for domiciliary care. And as of yesterday, we had 65 people looking for domiciliary care that we couldn't find any for. So that's the market that is really one to be in if you want to be a care provider in this county and in practically every county or every area, every locality in the country, because that's what people want. And what we have found is that agencies have been better in the pandemic at working together. So we've often had two agencies working with a family rather than one, to give them some consistency, but also some flexibility. We're doing some work, as you can see there in the report, about reducing the carbon footprint and trying to get providers to work in localised areas rather than drive all over the place. And that seems to be getting a good response. It's also much easier for the staff to do if they haven't got to drive 20 miles between each visit. They've only got to do a little bit. We've, for the first time formally, had a combination this winter that we're testing of our community provider in Gloucestershire Healthcare Trust and Health and Social Care Trust, I should say, Health and Care Trust, get it right, GHC, combining the community provider with private or charitable organisations to work with people. And that's quite interesting. We're also doing the same with reablement, getting reablement cases shared between our reablement team, which are employed by us but managed by the health service, and local providers. So that's a new test for us. I mean, it's not something that's happening in many places, but we'll see. We're trying that out this winter to see if it's doable. And so far, it's been going fine. So again, happy to have questions. I'll jump back onto my other screen so I can see people when they ask the questions.
Thank you, Margaret. Do we have any questions for Margaret? Ian.
First of all, Margaret, that last comment that you made about how domiciliary care demand has rocketed and people aren't being able to find the domiciliary care, I really think that that's something that this committee needs to keep tabs on, because hopefully the market will adjust and we'll find that there is not this gap between demand and supply. But we really need to know if that is the case, particularly if things are as fast moving as you're suggesting, that this is quite a fast moving situation. Anyway, but I've got, so if we could do that. But secondly, I have two questions for you. And first of all, it's about the long-term viability of our care homes, given that the decision has been made to disallow discharge of COVID-19 plus positive patients. Actually, it's more about our community hospitals, this one. Since we're not discharging people directly into our community homes now, do we have the capability in our community hospitals to cope with this? Does GHC believe that it has this risk under control if those positive patients are being discharged from our two main hospitals, and the expectation is that they'll come to our community hospital? And secondly, Margaret, I know that this second point has been made before, but I really struggle to understand this, and I'd like an explanation. It's noted that 700 people with disabilities have been exported for other parts of the country into supported living in Gloucestershire, and this is approximately a third of Gloucestershire's provision. And please, can you explain what, through ordinary residents and the application of the Mental Health Act, this means in practice for the council taxpayer in Gloucestershire? And please, can you spell this out for us, for the record, because I'm very worried that council taxpayers in Gloucestershire are ending up paying the bills that should be paid by council taxpayers in other parts of the country. So that's my two questions, one on community hospitals and one on why are we paying for these people, and what are the facts on the second question?
Thank you.
Okay. So going to the first one, yeah, we made a decision early on between the partners, acute, community and local governments, that ideally we would not want to admit COVID positive patients from the hospital into care homes, not least because of our experience in the first wave when infections were high. That's under review 3 times a week at the moment. So we looked at it again yesterday to see about the numbers. We started with Tewkesbury being the COVID positive community hospital. Yesterday, there was an outbreak in Lydney, so they opened the doors of Lydney for COVID positive discharges. At some point, we may have to go to the private third sector and ask if any homes would be willing to take them. One of the problems with this whole model is that there was no discussion between the Department of Health and Social Care and local government, DASIs, anybody else that's has a part to play in whether this model was a good one and whether it's going to work or not. And it was, if you looked at the instruction, we were given 3 days to identify care homes that would take COVID positive patients. The word was ideally within 3 days. We're now a month on, and there are probably only 80 care homes nationally that have agreed to do this, and 3 of the big brands have declined the offer. And that's quite an interesting position, because whilst they are lacking income, and this is guaranteed income, and remember it's block income, so they could have 10 beds in a wing dedicated to discharged patients and not take a single one because there isn't anybody to take. Because actually the numbers of COVID positive patients on discharge is still very low, particularly in Gloucestershire. So proportionately, most of the people have recovered by the time they come out, so they're not positive anymore. So I've been invited to go to what's called a surge planning meeting on Thursday, which the Health Service have called nationally. And I've been invited to the Gloucestershire one, which is good because most local authorities won't be invited, but we have very good colleagues here who always remember to include us. And I think one of the asks will be, have you got in mind any homes that might say yes? And obviously we do, because there is going to be a shortage. My concern, as you might expect, is that I don't want. I mean, I don't have the right to say what I want or what I don't want. It would be unfortunate if other authorities start placing people into Gloucestershire because we have capacity, because we are then actively bringing in people with the virus. And we know that once you get a virus into a home, it will spread. It doesn't matter how good your PPE is, but the nature of the combination, and Sarah will correct me if I'm wrong, but I do have a particular view on this, but I think that without doubt, people at work are doing exactly what they're required to do. They're wearing their PPE, they're keeping their distance, they're washing their hands. I'm not quite convinced that they're doing that when they're at home. And so that's my view, and it's completely uneducated view, of why we have high numbers of staff or increasing numbers of staff with the virus, plus the fact they're living in their own communities and they have teenagers and all the things that we all know about. So I do worry about bringing COVID positive people from another hospital in, not least because it increases the potential for us to have a bigger number of people with the virus. But it may get to the stage where we do have to have some homes, and we are just doing a sort of under the wire check to see if anybody wants to do it. But as I say, it's not been a popular move nationally or locally, and that some areas in the southwest particularly have got no COVID positive routes for discharge at all, because they don't have any community hospitals and no home has been willing to do it. And again, I was on a regional meeting yesterday because the NHS is so concerned about it. So that's that one. Respect. Any questions on that before I move on to ordinary residents?
Any questions? How can we sort that, Margaret?
Well, sadly, I don't have any formal authority to stop anybody coming in, but I have I did get wind of one local authority that had designs on 40 beds, and I was able to dissuade them. But unfortunately, some other poor authorities inherited them instead. But at least they're not coming to Gloucestershire, which at the end of the day is my primary concern. But I don't think it was a well thought through policy, to be blunt. Because really, if people are sick, they should be in hospital. They shouldn't be in a care home. Because, you know, some of these people are very, very frail. And, you know, we know that we don't know enough about long COVID, but what we do know is the demand for domiciliary care is because the people being discharged from hospital are really quite poorly. And they're needing, you know, 4-6 visits a day, whereas they might have only had 2. So, and they're needing therapy, which is the other great shortage, you know, physiotherapy in particular, but also OT, but physiotherapy because of their lung conditions. So it's a big strain on the resource that we have. So the more we can do to keep people in the right place for the right amount of time, the better.
But that's almost impossible, isn't it?
Well, we're just about holding our own. We're just about managing. But as I say, it's on a daily basis, you know, we look at it several times a day. There are 2 calls a day now to actually look at who's waiting for what and what we might do tomorrow that's different. The hospital, I have to say, to be fair to them, have coped admirably, both in the first wave and since. And if you look at the results of people that they have recovered from COVID, it's really quite impressive. We're very fortunate to have such good staff and such good facilities. Now, they may be a bit scruffy in places, but yeah, we were one of the first hospitals in the country to have perspex screens. So the amount of beds that they were planning on standing down didn't happen because we were able to use the space more effectively. I say we, I should say they, because it's nothing to do with me really, but we are a system after the end of the day and we all contribute. So I think we are in a very fortunate position. I don't know, Sarah, do you think the same, or is she still there? Okay.
Sorry, just trying to come off mute. I completely agree, Margaret. And I think that Gloucestershire has a really strong history of working together across health and care, and I think that's testament to our partnership working. So I agree with everything you said.
Good, that's good. Right, shall I go on to ordinary residents?
Okay, so yes, thank you, please.
This is the half-hour lecture. I'll try and make 2 or 3 minutes. So under ordinary resident, when somebody lives in a county or lives in a wherever, and you register as a resident and you pay your council tax, then your council becomes responsible for your statutory care should you require it. It's slightly different in terms of health because it's whichever GP you're registered with that CCG takes responsibility. And you will know that that comes into play for us on all of our borders, and we all have so many of them, the biggest one being Wales, where if somebody has a Welsh GP but a Gloucestershire address, then they're subject to 2 different sets of rules. Most of the time, nobody notices. But the problem with, when we got the Care Act, which was 2014, it was written, 2015, it was implemented, we had thought that we had done enough work nationally to persuade the government that the ordinary residence rules should transfer in terms of they should remain with whoever the council was that placed the person. That's what we had in the Community Care Act. So in the Community Care Act, if we as Gloucestershire placed somebody in Yorkshire, then we were responsible for their payment until they died. What the Care Act did was it changed it. And so it said, whilst the placing authority is responsible for somebody, they're only responsible until that person has a crisis that then puts them into the legislative procedures of the authority. And the biggest cause of that is the Mental Health Act. And so if you've got a primary mental health diagnosis or indeed a secondary diagnosis and you end up being sectioned, which obviously happens quite a lot, then if somebody has been placed into Gloucestershire by Devon, and Devon is paying the bill, and invariably these individuals are quite complex by the nature of their diagnosis. and their conditions and their behaviours, and therefore they're often very expensive, as in thousands of pounds a week. So if Devon places somebody in, they'll pay for them. But if that person then has a mental health crisis and is sectioned under the Act for assessment or treatment, when they get discharged, they become the liability of Gloucestershire. And because we have so many, and I don't know, I'm sure you can remember, we've spent years writing to the government and to anybody that would listen about this. We've had arguments over cases. We had a situation a few years ago when, funnily enough, it was Yorkshire, placed somebody here who they knew was really vulnerable. It was inevitable that they were going to become ours. Now, some of them don't. Obviously, there's some people that the care that they have is sufficient and their diagnosis is well controlled enough to keep them stable, and that's what we're interested in. But there are a huge number of liabilities, and I don't wish to sound dismissive about people, but the financial liability, as you say, for the council is always a risk for a group of people that are placed in here. And it's one of our reasons that, you know, we're always trying to influence planning decisions and very rarely getting any success, because the more providers we have in the county of specialist services, the more of these people we're likely to have. And that's the situation with learning disabilities, in that a third of the people who live in this county in full-time care are not Gloucestershire residents, but could potentially at any time become one. There's the other issue is that, of course, the legislation is different for health. So if those individuals who live in those care homes will get the NHS services completely free, because they're registered with a local GP, but the local authority is different. And we've got a case at the moment whereby an authority had placed somebody when they were 16. They're now in their late 20s. They want to move them into independent living in Gloucestershire. And we've had significant discussions about whether this is the right thing for this individual. But the reality is, we know enough about this individual, because the health service has been involved with him since he was 16, that the likelihood is he'll go into independent living, and within 12, 24 months, he will have collapsed again or relapsed, I think is probably the correct word. And we will he will become the responsibility of Gloucestershire for the rest of his life. And I completely understand that people want to live somewhere that they want to live, but we've all done it. You know, we're all living somewhere, hopefully, which is where we wanted to live. And if not, we all have the right to go and live somewhere else. And, you know, you can't argue that just because somebody has got a long-term diagnosis or a particular disorder, that they shouldn't have freedom of choice to where they live. But most of the people we're likely to inherit have not chosen to live in Gloucestershire. They've been put here by their council provider, and obviously many of them have got used to it and quite like it, and probably wouldn't want to go away if they chose. But it is a substantial liability, and it doesn't work the other way, because we very rarely place anybody out of county. We never have in the last 10 years that I've been here. We've actively kept people close to home. But some authorities don't have any specialist services, and instead of designing them for themselves and developing them, which the Care Act asks of the DAS, they've chosen not to, and therefore they use other people's. And unfortunately, we are a county that attracts providers of those services. That may be a good thing in many ways, but we have too much of it, and therefore that's why we have so many people in the county that have been placed by others.
We can say no, Margaret, can't we?
We can't say no. No, we don't have any authority to. And the providers, you know, I mean, we have some providers who actively seek external placements, because some authorities will pay very significant amounts of money to have somebody somewhere else. Unfortunately, it causes huge tensions amongst the officers, because, you know, we all know who we are, and we have big conversations about things. And it's happened in COVID. You know, we gave 10% supply relief to all of our providers for 6 months. Yes. Many authorities gave 5% for 2 months, you know, but those people are in our county, they're in our services, and those services were not getting the sort of money that we were giving them from those people that placed them. So I've had numerous arguments this year with my colleagues about fairness and responsibility. But
are you saying there's nothing we can do about it?
No, we've tried to challenge the law on many occasions. I mean, what we have to do is to be as vigilant as possible and to try and keep people at the peak of their condition, so that they are well maintained, that they're taking their medication, that they're well supported, etc., so that we try not to have them in relapse. That's the best thing we can do for them, and our health colleagues are really good at that. And they look after them as if they were their own, because for them they are their own.
Yeah.
But it's a quirk of the law that is not great. I mean, and it doesn't happen anywhere else. So in education and in health, wherever the person goes, the money goes.
The money goes with them.
Yeah, but it doesn't in social care. It was a lost opportunity, in my opinion, when the Care Act came in. But there was no appetite to go back and correct it. But that doesn't stop us moaning about it and bringing it to the attention of our professional leaders at every opportunity possible. Who knows, if we ever get a green paper, it might sort it. But I doubt it.
Okay, something to remember. Cool. Thank you, Margaret.
Sean's waving at you.
Sean, sorry.
Sorry, well,
And Jeremy too.
I was just going to confirm, this is something which I've lived with for a very long time at the National Star College, which has had this problem. I mean, Star College, I'm actually no longer on the board. I retired back in the summer, but this is a long running issue for them. What we've actually done, which I hope does help the county, is that we've gone right up the scale, that we get seriously students there with serious disabilities, which has reduced the number of students being able to come and live in the county. But if we go back a few years, that was not the case, and there was a lot of students going to Star College, like being there, and then stayed in the county. It's a huge problem. It's a huge problem. It has been there for a very long time. Yes, I mean, I think what we have to be proud of in Gloucestershire is that we do have these fantastic facilities. But I can tell you 2 or 3 counties who I know positively refuse to have actually introduced any one of these sort of facilities, because they know what the cost is going to be on them. And some of them are very close to us. In fact, we border on some of them.
Yes, you're absolutely right, Sean.
And you would say, I guess, that we're being taken advantage of.
Would I get that strong? I think there may be some authorities that would take advantage of us. Yes, probably. If I had to lay my life on the line for it, I think others actually quite genuinely. You know, if you've got a facility like Star College and you've got a disabled son, then that's where you would want them, because the service is so fantastic. The problem for us is, as indeed for us, whether we have a disability or not, you go to school with a bunch of people, you learn, you live with them, you socialise with them. Why do you want to leave them at the end? So, you know, the likelihood of them going back to whence they came, or from whence they came, is about, 1 in 10, I would think. And so I just think it's unfortunate that the law doesn't support practice, because the practice is that we have freedom to go where we want within our own restrictions, obviously.
Yeah.
But sadly, the law doesn't support that.
No. Jeremy?
Yeah, thank you, Chair. I'm getting a bit lost about where we are on the agenda, because I wanted to go back to the report on the care homes, and I'm assuming we're still there. But I'm confused about how we're calling people, because I've just raised my hand, it's been raised for some time, and didn't get called. But I just wanted to note the issue about the fact that we've got 20% vacancy in our care homes, and that we've got an increase in applications for domiciliary care. And that's not surprising, is it? Nobody would want to put their elderly mother or father into a care home at this point in time when we've got a pandemic, and we know that on the first wave, so many people in care homes died from COVID-19. So I was a bit concerned, Chair, when I read the report saying that we're not going to transfer any COVID positive cases from hospital to our care homes, but then it's being reviewed every other day. Surely we've learnt the lesson from the first wave. Maybe this is a question to Cathy Williams. Will you be giving instructions to the officers that nobody should be transferred from the hospitals into our care homes if they're COVID positive at that time? We cannot introduce the infection back into our care homes. It would be a massive failure of public policy. So I want some reassurance that this administration is not going to do it again. Half the people that died in the first wave were in our care homes. And we mustn't be transferring people in that are ill with COVID-19 and that are positive. It must be clear. No, it must not happen ever again. Haven't we learned the lesson from the first wave?
And Margaret, can we give Jeremy some assurance?
Jeremy, I'm sure Cathy will answer your question from a political point of view. From a professional point of view, that's exactly why we have freed up community hospital beds to keep those people in. We have to review it on a daily basis for two reasons. One is just to make sure we've got capacity. And obviously, on one day last week, I think I'm right in saying we had 128 referrals for domiciliary care within a 12-hour gap. I mean, that's twice what it normally would be. So that's the first thing. But the second thing is this is national policy. We were given direction from the Department of Health and Social Care to set up COVID positive beds in care homes. It wasn't us wanting to do it. It was a direction from government. And we are being challenged both locally, regionally and nationally as to why we haven't done it. And as I say, I was called to an emergency meeting yesterday with NHS England at 3:15 to ask me directly, why have you not done this when you were told to do it? And I gave them the reasons that you gave, and very similar examples of saying that also some of our homes are not suitable because the rules around passing the CQC inspection to be COVID positive recipients of discharged patients, it has to be a separate wing. It has to have a dedicated team of staff. It has to have an outside door in that's separate to the rest of the building. It has to have all the right PPE. It has to have all the right equipment and screens and stuff. It has to have the necessary clean. I mean, it's not an easy situation. The last set of figures I saw nationally, a third of the homes that had been put up as proposals failed the CQC inspection to be able to take COVID positive patients. But there are about, I think, between 70 or 80 nationally that are, and very few in the southwest. But it is a national direction, or directive, should I say? But we will resist it, and I'm hopeful that we can get through without having to challenge it. But as I said, we've got a a Gloucestershire meeting on Thursday afternoon, specifically about, so how are you going to manage the surge then if you're not going to use care homes? And that's been called by the NHS, but I've been invited and I will represent the council there.
Yeah, well, I would suggest that we resist, and we will resist, and we make that clear, and that we use the community hospitals for additional capacity.
Cathy,
and that you do keep everybody on this committee up to date of whether this is going to happen. But we know what happened the first time round. You know, there's people in these care homes expect to be kept safe, and to introduce somebody with the virus active at the time of their moving them in is just not on. And you also mentioned in your report about some of the care homes. The pandemic has exposed the unsuitability of some care homes buildings in respect of infection control and social distancing. I wonder what we're going to do with that advice, because, you know, COVID-19 isn't the only infection elderly people can pick up in care homes, and others can kill them off earlier than they should be the case. So I think it's important that we actually look at what the situation is with building of new care homes, and the issue to deal with care homes which have got poor infection control, and whether it can be resolved or it can't be resolved. And I wonder whether we're going to report on that and identify those care homes that quite clearly can't provide proper infection control for the elderly residents that live there.
I think Margaret's given us assurance, though, Jeremy, that that is not happening, that we are not accepting people with COVID, and that we're being criticised for that, may I add.
Yeah, and Jeremy, just to pick up on your issue about suitable homes, I know I've said it here before, and I'm getting to be a bit like a broken record, but I'll lay my age for that. But when these homes were set up, and when people set them up, they were care homes, they're not care hospitals, and therefore they were never required to have the clinical standards that we now need to be able to cope with the pandemic. You know, they managed just about with flu and various other bits and bobs, but the pandemic has really challenged them, and they are physically unsuitable, they're materially unsuitable, they don't have the right, you know, a number of care homes, for instance, have not been able to allow visiting because they don't have a separate outside door that somebody can come in, or they don't have a conservatory or that can be cleaned every time or whatever. You know, they were meant to be somebody's home. They were not meant to be clinical spaces. You know, they're full of soft furnishings and cuddly toys and plants and things, all the things that you wouldn't have in a hospital. So I think it has dramatically changed the way that we expect our care home providers both to behave and to actually have the facilities. And I've said it before, you know, we would expect to see a resident in a care home being given a hug by a member of staff, whether it's the person delivering their meal or whether it's the nurse looking after them at night time. You know, all of that has gone, which is why the whole issue about isolation and loneliness is so important. But we've got to find a middle ground somewhere that they can be safely looked after, but also appreciated and treated as if they are living a normal life.
And that's why, Margaret, it's so important that we don't reintroduce the infection into these care homes, because
I think you're talking to the converter, Jeremy.
But good. Sometimes you need to say it a few times, Stephen, to get the message over. I've done it. All right, I said my piece.
Kathy or Carol?
Thank you, Stephen. I want to support what Margaret has said. The move in Gloucestershire is to sustain the care homes, to manage and care for people. And we're really working very hard to actually enable people who are COVID positive to be discharged from acute services into the community hospitals. And that's being reviewed on a daily, twice daily basis. And we'll continue to do that. And Margaret will represent the county's view at the meetings she's going to this week. And we'll obviously give feedback to the committee as we can.
Thank you. Kathy?
Sorry, I haven't got really anything else to say than echo what Margaret and Carol just said. I mean, the thing is, with the pandemic, like all of us, we've learned an awful lot what's happened. As Margaret said, these buildings were built years ago. They've got narrow corridors. Some of them haven't even got a toilet. They're sharing toilets and all sorts of things. So the whole programme we will be looking at in the buildings. And I think with Jeremy, it's all very well. We don't, as the government said, we had to move people. It was in a state of panic, let's be honest. Everybody was moving fast. We didn't know what was going to happen. This time it's a much more measured approach, I would say. People are much more prepared for what's happening. And we certainly don't want to bring COVID into homes. But you must remember also that the staff, there's a big turnover of staff, and a lot of our staff are sometimes moving in one building to another. We've got all these problems that we're trying to address. And it's not just about people moving into a home who have COVID. We've got to make sure the staff are okay as well. And then it just goes on and on. Then you start with the deliveries and everybody else. It's a big operation. And I think, you know, as Margaret has reassured you, we do not deliberately want people to be moved into homes with COVID, but we can't guarantee that we won't have people in these homes with COVID. And I think that we have to make that very clear. Thank you.
Thank you. Right. I think, are we now going on to Sarah?
No, well, Steve is waving at you, Steve.
Sorry, Steve, sorry, can we hear your voice now?
Well, I've moved onto my iPad, so thank you. If you don't mind, Chair, I'd just like to go back and just ask about. I've got two questions. One is about the safeguarding. I read in the report, thank you, regarding the sad loss of a rough sleeper in Cheltenham, who had been sleeping and was dealt with by all the agencies. And I have mentioned it before. I have a rough sleeper in my division who has been sleeping for 2 years, and we're coming up to winter again. He's been dealt with by all agencies. I just wonder what sort of review came from the Cheltenham one, because, you know, I am really concerned that this is going to happen in my division if we get a severe winter. And, you know, what can I do? Can we do anything more following the review?
Kathy's got her hand up.
Hi, sorry.
You're right, we can hear you loud and clear, Kathy.
Can you hear me?
Yeah.
Yeah, sorry. It was saying it was still unmuted. First of all, our approach to people who are living on the streets has completely changed over the last year. We've been given quite a lot of money by the government to make sure that people are brought in and in safe places. Now, we can't get every single person in because they've got people who literally refuse to. And that's probably about 19 to 20 people who refuse to come in whatever. But for the first time, a lot of people are being housed now in accommodation and are beginning to turn their lives around. We've had extra money last week promised by the government. We have a severe winter policy that we use anyway. So when the temperature gets to a certain level, we've got to bring people in. And again, you know, you can't pull people in. It's a free country. If people want to stay on the street, we can only ask them and advise them to come in. It's unfortunate you do get the occasional death on the street because these people are living on the streets and they have other issues. A lot of them have drug or alcohol issues. They're very poor nutrition and other health issues as they get older. So it is something I can't say won't happen again because it probably will. But I can try and assure you all that we have now, for the first time in Gloucestershire, a lot of people living in accommodation who were living on the streets. And this can only move forward. And what we're trying to do is get people settled. It's proven that people are finding that they like being in accommodation. They're trying to get their lives turned around. And we've now got a programme, we're moving them on into accommodation. And this is all going on behind the scenes. So if that can reassure you, that's all we can do at the moment. But we're doing our best. And I think, considering the year that we've had, I think we can only thank the officers in the district councils and at the county council who've been working hard to make sure that these people are safe.
Yeah, thank you, Kathy. I realise that, but it's just that, you know, everybody has tried. If this person doesn't want to, as you say, there are certain people that don't want to, that, you know, one morning somebody is going to find this guy, you know, and it is worrying. But yeah, okay, thank you. Could I just ask another question, please, Chair? In Margaret's regarding dementia placements by 2025, it says in the report that there'll be more placements needed for dementia. Knowing that we closed Wyatt House because it was not deemed suitable for, and having visited it, I quite understand that reason. Are we looking forward to now? I mean, 225 is going to come round very quickly. Are we looking for a purpose-built building to for more dementia clients, please?
Kathy has a hand up. Margaret and Kathy.
Yeah, well, I mean, I'll go in first. I'm sure Margaret has more detail than I am. I'm involved with the dementia steering group in the county council, and it's working with our colleagues across the different health trusts. Now, dementia is something that people always used to think people had to go in a home. And Margaret and myself know that a lot of people with dementia are now being managed in their own homes with family support. And it does get to a point when that support does break down. Particularly if the person is wandering all the night and people needs a break. But then we try to offer respite care to make sure that those people can still remain in their homes. But when it gets to a point that a person can't stay in the home, then we will have to provide care. And I think that's part of our overall strategy looking forward in the next few years of what we're providing in the way of care homes, which is the question that was asked by Jeremy, but about where we're going to go with dementia. Dementia is rising. There's no doubt about it. We're going to have more people with dementia in the next few years than we've ever had before. But it isn't all about putting people into homes. It's about trying to manage them in the community. And that could be with some extra daycare. It could be with people sitting in the house, giving breaks to the carer. And that's the way. But I think I'll let Margaret answer the rest.
Thank you, Cathy. No, you're absolutely right. And I think I mean, the thing I say to most people is that if we can give people confidence that when they've got a crisis, that somebody will be there literally within minutes, then they are more likely to keep their loved ones at home because they know that there's somebody at the end of a phone for them. And I think one of the things we've learned over the years is that people hang on to their domiciliary care or hang on to their package of care because they're frightened that if they let it go, they'll never get anything back again. So it's changing the way that we work. And I think we've demonstrated in the new model of working in the community teams that social workers have done that. They have literally responded within minutes to people, and that's made a difference. And that's one of the reasons we've had so few complaints, I think, this year. The other issue is, yes, we are looking at providers diversifying and specialising in dementia care, and that's both in terms of home care and supported living, extra care housing and residential and nursing care. We know we'll need more nursing dementia beds, and we are actively trying to develop those with various providers and looking at, again, Mary Morgan's doing some work at looking at a housing scheme with specialist providers who would be able to manage people with dementia. Because whilst we do have some very nice extra care schemes across the county, particularly in the private sector, they can't cope with people with that level of need. And invariably that somebody will move in there in their late 50s, early 60s, and then 10 years later, we'll be moving them again. That's not what we want. We want somebody to have a stable life and for them to be able to keep living with the people that they've lived with for the last 30 or 40 years, provided they still want to. But it's, I think it is different. Cathy's absolutely right. The first port of call now is not for long-term care, but there is a moment for many that they will need something more than we can give them in their own home. So it's a balance of the two. Sarah, I'm mindful that you were waving your arm and I don't think Stephen saw you.
Sorry, Sarah, have I ignored you?
No, I was just going to, it was about the previous point, actually, about Steve's point, about the individual that Stephen Ruff, just say that following the last scrutiny committee, we did ask our services to make contact and because the individual has capacity, they've chosen not to engage with the services. So we did make it, it's not the first time the services have tried. So they did really try to engage this individual, to try and bring them into our homeless services. And I'm not quite sure, that wasn't very successful.
No, thank you, Sarah. Yeah, I was aware. Thank you very much for following that up, and thank you, Margaret. Yeah, thank you. Margaret,
have you completed your report?
Well, I've done 2 out of 3. I'm sorry, but there's another one to go yet. I'm sick to death of listening to me with my black country accent. I try to keep away from Dudley, otherwise Andrew will be having a few words. Okay, my third report then is the usual report to scrutiny in terms of what we've been doing recently. And I won't bore you to tears by reading it all back to you, but you can see that the types of things that we've been doing, and we were again specifically asked at the last meeting to bring a report back on what we were doing about technology and digital. So there's a summary there of the tech work we've been doing. And I think, as indeed with most places in the country, and I'm sure it's the same with your emails, there's not an hour that goes by that I don't have an email from somebody who's got some whizzy bit of kit that they think that we need to buy. But invariably it doesn't work. And it certainly doesn't work in the Forest of Dean. And so we are being careful as to how we test some of this stuff, because it can claim to do all sorts of things. I didn't go to the national conference last week, our annual conference for social care, for various reasons. But there was a moment apparently where somebody was doing a talk, one of the directors doing a talk about digital equipment, and mentioned the name Alexa in the speech, forgetting that he had an Alexa in the corner of his room, who then intervened into the conference to say, "I'm sorry, I don't know the answer to that question." It was just one of those moments where you think, this is probably the leading director in the country on technical stuff, because that's his absolute delight, and he still managed to mess it up. So I'm very happy to take any questions, whether it's about tech or anything else, but feel free.
Are you waving, Brian?
I am. It was just a question from the report on the
I think we're having problems with your sound.
And social work. And there's a comment on page 85. Can you not hear me?
Well, you're a bit like that comedian. The stuttering voice.
Okay, well, I'll try again. I'll put it on the chat.
Thank you, Brian. I'll pick it up. I'll pick it up.
Apply that. Okay.
Thank you. Any more questions while we wait for Brian? No? Brian, are you sending us a chat question, Brian?
I'll pick it up and answer it straight away.
I think we're losing Brian's connection altogether. Shall we move on, and I'll keep an eye out for the chats?
Yes, thank you. Does that complete your report, Margaret?
It does indeed, sir. Thank you very much.
Very much indeed. Can we now proceed to Sarah, who gives us her report?
Thank you. I've got two things. So there's the written report you've got before you, and then the COVID update. So shall I do the COVID update first? And I can share my screen. Just bear with me. I'm going to do it. Hopefully you can see that.
Yes, that's fine. Yeah. And we can see the current slide and the next slide.
Yeah, that's clever of me. Okay, so obviously as soon as we put together any report, it's out of date. So I'm aware this refers to week 44, which is 26th of October to the 1st of November. I'm conscious it's the 10th of November today. It contains data up into the 4th of November. So are we going to move forward? There we go. This particular report talks about that time frame. At that point, we had 710 cases in the past week, and we were up to 4,748 cases in our county to date. The latest data today means we're up to 5,304 cases. The numbers are rising rapidly, which of course is a concern. You can see there at the bottom the curve of our cases from the 28th of February back earlier this year, and we can see that we're seeing much higher numbers in this second wave. Some of that can be explained by the increased access to testing. You can see here also on the map about the numbers of cases in the districts. This again varies quite a lot. So the most recent data today would be that Cheltenham are at a rate of 110 cases per 100,000. Oxford is now 146. Forest of Dean 91 cases per 100,000. Gloucester City 151 cases. Stroud 160 and Tewkesbury 87. So you should be getting these in your daily update from the Hope Health Protection Desk in my team. So we're seeing an increase across the county. We continue to look at the data, and we've had a good look at Cotswold and Stroud in particular, because up until now, we've seen generally higher rates in Gloucester and Cheltenham. And we thought that was because they were a more urban area, closer concentration of people. Now, we know we've had outbreaks in our 3 universities, but the increase in cases in the Cotswolds cannot just be explained by the cases at the Royal Agricultural University. And what we're seeing there are more cases either in the 19 to sort of 35 age group, and then some that are in the very, very older age group as well. So there is obviously a link to care homes. But we also have a hypothesis that it's difficult for us to test this, but we wonder whether that we've got people living in the Cotswolds who up until lockdown were going out to other areas to work, whether that be Bristol, Swindon, Oxfordshire. It's quite difficult for us to test that, but we wonder whether that might explain some of the higher numbers. And obviously we look at the data that comes through the contact tracing system, but it's only as good as the data that people put in. So we often don't have definitive answers as to where people
We do have a large employment leakage though, Sarah, in the Cotswolds.
I mean, it's a beautiful place to live, isn't it, Gloucestershire as a whole? So it wouldn't be surprising if people then work outside of the county but choose to live here. So as you can see, a clearer view of our epidemic curve here with the higher numbers as we continue to go into wave 2. In terms of the weekly numbers there, you can see this particular week, the Monday the 26th of October to Sunday the 1st of November was 710. In the preceding sort of 7 days, we would see, what we tend to do is ignore the immediate 5 days preceding the date, because we know it takes up to 5 days for the testing data to come through. So some of the briefings that you might get have a rolling 7-day average. So the 29th of October to the 4th of November, there were 810 cases recorded. So it's going up, and we're seeing week on week, sometimes a 30% rise in the number of cases. It's really concerning. And I've already given you some of the data for care homes earlier on, but we are seeing that increase as well. And really sadly, we've seen an increase in deaths recently. So this talks about mortality. You would have heard me talk about this before. So the red bars are the non-COVID deaths, and the blue bars are the ones where COVID has been recorded on the death certificate, either as the main cause or a contributory cause to death. The dashed black line is our deaths from all causes. So it's the more reliable way of trying to track to understand the impact of COVID on our rate of deaths. And that dashed line is our 5-year average, and it enables us just to check where we are in terms of what we would expect to see at this time of year. And you can see that our number of deaths, thankfully, are actually below what we would expect for our 5-year average. But we had a good period of time over the summer when we didn't have any COVID deaths at all. And in the last week, sort of the data up until the 23rd of October, because there is a time lag, we've had 3 deaths in the week preceding the 23rd of October. So something is shifting, and this is obviously deeply worrying. The data on the National COVID Dashboard on the .gov website has got a lot better. They now produce some interactive maps. So this is an image from that. So as you can see, the darker the colour, the higher the prevalence. So you can see some dark sort of maroony purples around the northwest, and Bristol now is that colour because it's got a rate of over 400 per 100,000. Gloucestershire as a whole. Sorry, Stephen.
Some in South Wales too.
Yes, absolutely. Wasn't that long ago we were green. So you can see that we're surrounded. Herefordshire is green. We've got the blue, the same sort of the West Midlands, lower part of the West Midlands. That is the same rate of us. So we've got between 100 and 200 cases per 100,000. And then, of course, we've got, it's difficult to see, but obviously we're seeing high cases in North Somerset, South Gloucestershire and Bristol as well. And the green, largely the southwest is green. So as a region, we're seen as being a lower prevalence area, which is really, really positive. And there is some work going on at the moment to understand what work we could do at a regional level to keep us at this lower level. Because clearly we want to stop cases rising. This is the same map, but we've honed in on a key part of it. So the white areas are where the data's been suppressed because there's 3 or less cases, and the lighter green have lower numbers, but the darker blue, the darker the blue gets, the higher the cases. So you can see there in the text that as of the end of October, these are medium super output areas. They're smaller than a district, but bigger than a ward. And they're trying to highlight some of the areas that had the highest cases. So Minchin, Hampton and Amberley, had quite a high number of cases there, 21, and Cirencester South had 22. So we're doing some more work to understand what might be causing this. But the initial assessment is there's not one overall outbreak that's driving this. It's general community transmission, which is what most directors of public health in the Southwest are finding. We don't have a big point source that we can think, right, that's the cause. Let's go in and control that and bring down the numbers. It's general community transmission. And what we're hoping is with the 4-week lockdown, in a couple of weeks' time, we will see the impact of this and we'll see transmission rates drop. That's the plan. And the last slide is around the R value. So the R value is the reproductive rate. So how many people a single confirmed case is going to infect. So the R rate in the Southwest is still, it's been hovering around 1.2 to 1.5 for some time. This means that for every 10 people, they will, with COVID, then infect a further 15, and then and so on and so on, or between 12 and 15. This is sometimes because of our lower numbers compared to places like the North East and Yorkshire or Northwest, the R rate is not that accurate. And certainly we weren't using it a lot over the summer because thankfully we had very low numbers of cases. But now our numbers are going up. The R rate probably has sufficient power to be more accurate. So we are using it more in our interpretation and calculations. So I'll pause there before I go on to the mental health briefing to see if there are any questions.
Any questions, members? No? Jeremy and Sean.
Thanks, Chair. Thanks, Sarah. I'm interested in the stats. I mean, obviously, it's worrying that the cases are rising, and also the number of deaths are rising. But what about the number of people that are now being hospitalised as a percentage of the people that are being infected? And what about the percentage of people in intensive care units, and also the number of people on ventilators? And also, what's the situation like compared to earlier this year on the percentage of people in hospital that are recovering from COVID-19? And surely we know there's been quite a number of improvements in treatments and everything else. But it would be useful to see those stats as well, along with the global increase in a number of infections.
So I don't have access to the percentages. The most recent data I have is from last Friday. Margaret's waving, so she was on the Health Gold call yesterday. So Margaret, if you were on the Health Gold call yesterday, your data's probably more up to date than mine.
Yeah, so as of yesterday lunchtime, we had 44 patients with COVID in the acute hospital. We had one person in critical care, but they weren't there because they were COVID positive. They were there because they were recovering from surgery. So it wasn't COVID related. And we had, I don't think we had anybody actively ventilated, but there were 10 people on the high respiratory ward. So that there are 2 COVID wards. There's a respiratory section and then the CCU. And so the numbers are still modest, but they are twice the number they were the week before. And as of yesterday, there were, I'm trying to find the number in my head. I think about something like 14 people in community hospitals. They had 3 deaths the week before between the 2 of them, but none this week yet. And there is another person in CCU, but that's a young woman who attempted to take her own life and is in serious organ failure, but there's no COVID there either. So you just have to be careful when we read the numbers that we then drill down to actually look at how many of them are COVID related, because it is still relatively modest, but growing.
Thanks, Margaret. I think what's really reassuring is that my briefing last Friday also mentioned the 1 person in ITU and also mentioned 44 patients in the acute. So I think it is increasing, but I don't think we're seeing the levels that we were seeing yet in the first wave. And I think one of the reasons for that is that we've seen COVID move through the age bands. So in the summer, you might remember me telling you that we were seeing more COVID in the sort of 15 to 30 age group. And what we wanted to do was to keep it from the older age group who we knew would be more vulnerable to complications and hospitalisation. But it is clearly in our more older age groups now. I don't know if that answers your question, Jeremy. There's a question in the chat from Brian as well.
Well, I think it answers the question, because some people will pick up the virus, and it might help reassure some people that more so than in the past that they've got a much better chance of surviving the illness, and I think that's encouraging because that's good for the mental health of anybody that picks up the virus, frankly. So I think we do need to make it clear what the stats are related to the hospitals, and we've got quite a lot of capacity is also in the system in dealing with it. If there's only one on the ventilator and that wasn't somebody with COVID-19, then that's an encouraging response from our medical teams working in our hospitals, isn't it? And I think we need to get that message out as well. I know we've all got to take precautions to make sure that we don't pass on the infection or catch the infection. But on the other hand, I think it's important that if people do pick it up, they feel confident, more confident than they did in the past, that the medical teams will help them through it.
I think I think the medical teams would always have helped them through it. I think what they have now is a couple of treatments that we've learned through wave one are shown to be effective. I think there is something about this is the hospital's data, and we need to talk to, as Margaret was about to Deb about how we share it. But we can certainly do that. And I think there is something about messaging, because just picking up on Brian's point, whilst I am concerned about public compliance with the rules, we are seeing plenty of evidence of people not complying with the guidance. And the reason why our cases are rising is because people are not complying with the guidance. If we, and I know it's frustrating, I know people are thoroughly fed up of it, but if we washed our hands frequently, complied with social distancing, complied with the rules of the lockdown, wore a face mask and complied with test and trace, we wouldn't be seeing the number of cases that we're seeing. It's as simple as that. I think people are not complying for a variety of reasons, but I think there was some work done in region nationally that suggested that there's a real drop-off in people actually accessing testing now if they have mild symptoms, because they know they'll have to self-isolate, and they just work through it and just carry on. So there's a real problem around how we nuance our messaging, so we try and alleviate some of the anxiety around what if I catch COVID, which I think Jeremy is a really valid point, versus we don't want to give people false reassurance they don't have to comply with the rules, because actually if you get it, you'll be fine. But because we don't know, and there are some cases of with younger people catching and developing long COVID, which has had some quite significant impact on their life. Sorry, Margaret, you were going to say something.
No, I was just going to say, sorry. I was just going to say for Jeremy, Deb Lee puts a bulletin out every week with all the stats in. So how many people have recovered, how many people they treated, how many people recovered, the general state of the world, and most chief execs across the acutes do that, and so you can compare activity one to another. And I think I said last time, if not the time before, John Radcliffe in Oxfordshire in the first wave were talking about how many people they'd managed to get through the virus and how successful they were, but actually Gloucestershire hospitals had a much better success rate. From memory, about a third better, if not a little bit more. So it is worth just reading the bulletin that she puts out.
Okay. The other point, Chair, is that we had in the announcement yesterday of one vaccine that might well be ready for distribution by the end of the year, 90% efficacy rate. So I just wonder what plans and how far we are in advance in plans in Gloucestershire to make sure that we can get the vaccine, when it's approved, distributed throughout the county and encourage everybody to have their jab.
Margaret?
I've had my flu jab this year. I hope everybody else on this committee has had their flu jab as well.
Margaret, Margaret, or do you want to do it?
Well, I can tell you that as of yesterday on the gold call for the NHS, which I go to 3 times a week now, Gloucestershire has a plan to be able to mobilise a vaccination programme from the 1st of December. The national target would be to do over 80s first, and it will be quite strictly monitored to make sure that the right people get it at the right time. The problem at the moment is the vaccine hasn't been validated, so it doesn't have a licence.
That's
but
right.
We'll wait and see.
Can I just come in there just to add? So I think one of the things about mass vaccination was that I did some work on this for pandemic flu for the first pandemic 10 years ago, is that there are a number of different vaccines in the running at the moment. Clearly, we had the announcement yesterday, which was really positive about this 90% success rate. But I think the government's trying to cover all bases by considering the front runners of all the vaccines, and they all have different requirements. So one has to be frozen at something like -50. Others might require refrigeration. So to do this at a mass population level across the country is incredibly complicated from a logistical perspective, which is why the plan is having to be quite flexible. And I think, as Margaret says, we've got a plan. I would also say that if we do get a vaccine before Christmas, that would be fantastic, but it is just one thing available to us. We won't all get it at once. It will take a considerable amount of time to roll it out to the population. So we'll still be seeing cases throughout next year, and we'll still have to abide by the guidance to keep ourselves safe. So we wouldn't want people to get some false reassurance about the fact that we might be rolling out a vaccine around Christmas, because that's brilliant news, but it will take quite a lot of time to get to the entire population.
Sean, do you have a question?
Well, I just wanted a bit of clarification going back. Sorry, we've gone on a bit. Yes. I don't know what the population of the Cotswolds are, because it seems to me that when you get a smaller population, that these figures can hop around when you try to, just mathematically, when you try to do it per 100,000 people. And I think the Cotswolds population is well down from 100,000. So I do worry about the figures coming out from the Cotswolds purely on a mathematical basis. And the other thing is, I agree with the comment. I think that people are acting much more cavalier on this lockdown than the previous lockdown. I mean, I listen to I can hear the road above me going when the wind's in the east, which it has been earlier on this week and the weekend. And there's a huge amount of traffic going up and down the A417, for example. And I think the other thing which I think is also happening, which I've been told anecdotally by 3 different people, is a number of people have left to come down to their second homes in the Cotswolds, knowing that they've got COVID, so they can register and be more comfortable in the country than they can, say, in London or somewhere. But anyhow, my real question is, what's the population of Gloucester, and does that tend to influence the statistics at the end of the day?
Population of the Cotswolds, as I understand it, is around 90,000. And we tend to use a rate per 100,000 because it enables us to compare meaningfully between the 6 districts of different sizes. So we also look at the numbers, and we look at the numbers at ward level, which vary considerably. We look at the outbreaks in particular places, whether it be care homes or schools or universities. So we look at the data at a variety of levels. I think we have to be really careful what we release publicly, and as a country, we've been using the rate per 100,000 as the statistic that we use, recognising that the data does hop about a bit. It does move, you're quite right, for smaller populations. But that's the sort of the generally considered best statistic to use, and that's the one that we lift off the COVID dashboard on the national website to share with members every day. But I know that you're concerned. I think the issue about people coming to second homes, I think they were very much told not to do that. You shouldn't be travelling if you've got COVID. If they've just basically left at home number 1, got in the car, driven to home number 2 and stayed in the house for 14 days, the risk is minimal. And if the entire family do that, it's not desirable, but the risk is minimal. It's only if they go out and about once they reach their second home and they've got COVID symptoms that there's a real potential for spread.
Okay, thank you. Any more questions, members? Andrew.
Yeah, thank you. Oh, yeah, sorry, thank you. So a question for Margaret, her deadly accent aside for one moment. Margaret, you were talking about the stats that Sarah Lee's putting out once a week, I think you said, Margaret. Does she ever refer to the number of delayed cases of treatment of other conditions? For example, there's been a lot in the media about people on the cancer pathway not getting the necessary treatment that they require, that's desperate for them, in a timely way. Are there any stats, Margaret, on those sort of issues here in Gloucestershire, please?
I think so, yes, Andrew. And again, I can't speak on behalf of Deb because this is health information and I only get it second hand, so I wouldn't want to be quoted. But I think that we've done quite well in the county for keeping our electives up. I'm sure we could ask for some of that information at next week's Health Hosc. But certainly we were very quick, they were very quick to reinstate electives, and they've been running outpatients and all sorts of things. And as I said earlier, they were one of the first hospitals in the country to get all of the COVID protection stuff into place. So they've been very impressive, I have to say. Very impressive.
That's really good news. Chair, can I just come back very briefly? I've been very quiet today. Been very quiet today. That's good news, Margaret, and that's good to hear. Sorry? No, I didn't catch what you... No, I can't deal with heckling in this system. It's there's too much time delay to deal with heckling, Chair. But if I can just finish, Margaret, thank you for your answer, and that's very reassuring. And it bears out my experience where I still get pulled in for routine CT scans, and appointments are done by telephone, and it seems to be working very, very well. There is the fear that you hear anecdotally of people saying, well, I don't think I want to go to the doctors in case I have to go into hospital. And I try to say to people, if you think you're in trouble, if you've got an issue, please, for goodness sake, go. The local doctors are still working. The hospitals are still working. Do not delay it, because whatever you think you may have, if it's extremely serious, is not going to go away. So please do go today. Straight away. And just finally, one point on the vaccine. I heard Jeremy asking us if we've all had our flu vaccine. Well, I'm sure, all being responsible people, we will have had. I certainly have had mine. But just still a word of caution on what I've read about this vaccine that potentially could be, the one that we've all been waiting for. As I think Sarah was saying, there's still a lot more tests to do. It's got to be approved by the different authorities. You need two jabs, 21 days, I think I saw in between them. And also I was reading in the paper today that there are, I think, 10 or 12 different categories you have to go through before they exhaust all of the population. And I went down that list to see where I fit in because of advanced age and all that kind of thing. And people, even if they're getting on, doesn't automatically mean that they're anywhere near the top, or if they've had previous existing conditions. So, I do hope that people won't run away with the idea that everything's okay now, we've got a vaccine, it doesn't really matter anymore. Of course it matters, and people shouldn't get complacent because of the positive publicity over the vaccine over the last 24 hours, Chair. Thank you.
Thank you, Andrew. Carry on, Sarah.
Can I just talk through the report that's in the legal pack? So last time you asked me to come back to you with some information about deaths by suicide and the impact of COVID on mental health. So I'm assuming you've read the report. So we've given you the broader context of course, as COVID started and the first lockdown, we saw an impact on people's mental health and well-being. And we knew that it would exacerbate the people's mental health, particularly if they had other vulnerabilities. So, for example, it might be worse people with lower incomes, those not in employment, those with disability, or those with existing mental health problems. In terms of our response, we convened a mental health and wellbeing cell that sat underneath the strategic coordinating group as part of our LRF response. That was chaired by a member of my team, and that was a multi-agency group. And there was also a separate health system mental health cell that looked at access to specialist and non-specialist mental health services. And they worked very well together for a period of time. And what's happening now is that we're merging the two groups. As we were thinking we were moving towards recovery over the summer, there wasn't a need for two response groups. They will continue to work closely together to ensure that we continue to understand the impact of COVID on people's mental health and wellbeing, and ensure that services are able to respond appropriately. So we understood there'd be additional mental health additional mental health needs throughout the pandemic. So the next section talks about some of the additional services that the County Council has commissioned and some of the activity there. So we commissioned, in addition to our existing services, online mental health support for adults, online mental health support for children and young people, an anonymous mental health helpline through one of our existing providers with the CCG teams in crisis, and some additional counselling for adults whose mental health had been significantly impacted and they weren't able to self-fund. So you'll see there the activity, and the activity continues to grow, and particularly since we're now in our second lockdown. It gives an overview of some of the other work that the cell undertook, particularly around how to support professionals and volunteers throughout this period, understanding that they're also working to support people in mental distress. And then it talks about the additional work streams that we undertook there. Another piece of work they're doing, which is particularly important, is the dashboard to monitor activity levels around mental health services, but to try and use any indicators we can to understand what impact it's having on people's mental health. So that's in train at the moment, particularly as we saw attendance at local mental health services fall during the initial lockdown. So we move on to suicide now and deaths by suicide. So I think I've probably spoken to you in the past about our suicide work and how we do perform our surveillance and monitoring work. So we gain our official information on death by suicide from the Office of the National Statistics. And because of, thankfully, the low numbers of deaths by suicide, we aggregate the data over a rolling 3-year period. And that means that it's much easier to look at trends. It softens any peaks, and it gives us more data to be able to draw conclusions from. So the most recent data we have is from 2017 to 2019, where 170 deaths were registered. And you can only be called a death by suicide if the coroner deems it to be a death by suicide. So this explains the quite long time lag, whereby we can suspect that someone might have died because of the suicide, but it's only ever deemed to be a suicide once the coroner rules it. So for this particular period, 2017 to 19, our suicide rate was 10.2 per 100,000 for the county, and just was broadly in line with the national rate of 10.1. This is clearly still too high, and we've always prioritised our suicide prevention work in the county. It has reduced slightly from what it was in 2013 to 2015, where we were a bit out of significantly above the national rate. And as with the national trends, we see a much higher number of deaths in men, particularly younger men. So the report goes on to talk a little bit about our surveillance during the pandemic. So we've been looking at some of our real-time data. We're not able to share this in the public domain because of the sensitivity of it. And I think, despite our best efforts, it's too early to draw any clear conclusions from the recent surveillance data around trends or in suspected suicides during the pandemic. So I'm unable to specifically answer your question, but I think the report there is designed to try and provide some assurance that we are actively monitoring this as a system, and continue to pursue our local suicide prevention work. One part of which is an audit looking at, goes into some detail as to the circumstances around each death by suicide, and also the implementing the suicide prevention strategy across the county. So I'll stop there, and I'm really happy to take any questions.
Questions, members, please. Ian.
Thank you so much, Sarah, for this report. It's a really important report, and in many ways a very positive report against the context in which, as it says here, severe depressive symptoms have risen from 1 in 10 adults pre-COVID to 1 in 5. And amongst young people with a history of mental health problems, 80% stated the pandemic had made their mental health worse. But there's a lot of meat in this, and a lot of good work that's been done by many people in health and social care, a lot of people within the county council as well. So my first question is, can we somehow give this more publicity beyond this committee, because it's so important and such an impressive piece of work? But my second question is, just picking up how research suggests that suicide rates rise during periods of recession, and a rise in unemployment will also have a bearing on mental health. And that is intuitively true, but it's also fact. So given this is the case, we should surely plan to continue enhanced mental health support through 2021, since there'll be increased unemployment linked not only to COVID, but also to the economic damage widely predicted to be caused by Brexit. So will this level of support that you outline here continue, or maybe even be further enhanced into 2021? What is your answer on that, please?
We commissioned the services for between a 6 to 12 month period because we commissioned them quickly in response to the anticipated need. And we're working to evaluate the impact of those. Have they been the right services at the right time? Was it what people needed? And we can see they're being used. And then we're working with Tim at the moment on our proposal for the budget for the coming year. So clearly any decision about funding will be taken through the normal budget process. But we're very mindful of the impact of mental health, of both of COVID, but also of Brexit and just the daily stresses and strains of life and the cumulative effect of all these things on people. So we're very mindful of that. We want to understand if the services are the right services, and then we'll work through with Tim and the Cabinet how we might best fund those.
Give it some publicity to the report, please.
Yeah, I think there's something about, we get an awful lot of comms around, particularly on social media, trying to target these at the right groups, so particularly young people. So we've done lots of work on Instagram, for example. We've had a foray into TikTok, which was a new social media platform for us. We use Twitter a lot to try and promote the services. I think we need to be careful about how we talk about suicide and suicide prevention. So I'm very happy to take this back to the group and ask them for their expert view about how we might best promote the work that we've done around supporting those that have experienced bereavement by suicide, but also trying to prevent suicide during this time. So I'm happy to take that as an action.
Yes, please, Sarah. Thank you. Any more questions? Everybody happy? Thank you, Sarah. I think you've had a busy morning this morning. Can we then go on to Wayne, who's been very patient? It's been like a bit like being in a fire station, Wayne. You wait for hours and then suddenly all hell breaks loose.
Thank you, Chair. Hopefully they're not waiting around, and they are very busy supporting the work of my colleagues, Sarah and Margaret, and protecting the vulnerable people in our communities.
Yes, that's correct.
And if they're not doing that, they better be training, like coiled springs, Stephen. Thank you very much. Hopefully I'll be able to keep this quite short, as this is the only report, obviously, that I'm bringing on the agenda. I'll take it that you have read the report, and I'll just refer to some of the highlights. Just bring to members' attention that this week we have Her Majesty's Inspectorate of Constabulary Fire and Rescue with us. They started yesterday, virtually, of course, carrying out our COVID-19 response inspection. It's an inspection that they're doing of all constabularies and fire and rescue services in England. We are towards the tail end, so we have had some insight into how others have been inspected and some of the key areas of focus. You'll see in the report that it references their kind of top line things that they're looking at. So far, so good. It appears, I know Sarah was interviewed yesterday in her role as leading the County Council's response to COVID as the DPH. Several other members of staff being interviewed this week, and hopefully we'll be able to tell a very positive story about how fire and rescue staff, alongside other colleagues from the County Council, have stepped up to really support those most vulnerable in the community, or the colleagues in other parts of the public sector across Gloucestershire, so that they can do their jobs and provide frontline services as safely and effectively as possible. So I'm really keen that we get that message across. We will be inspected again towards the end of the year. No date confirmed yet, so members will be aware that there were 2 causes of concern from HMI following our first full inspection last year. They will be re-inspecting against those causes of concern. That's occurred once and will occur again. We expect that to be towards the end of November, early December, around our business fire safety function. And whilst here, they will take a more interested view as opposed to an objective measures view of the cultural development and the progress that we're making in terms of inclusive culture, driving out bullying, harassment, discrimination, and also more ethical and fair promotion pathways and development of staff. And again, I'm pleased to say, as we move through the report into the second section on improvement board, that you can see there from the 118 audit recommendations that were tabled for GFRS particularly, and some of those were council-wide. We're making significant progress through those audit reports, and we have prioritised them, which does create tension. So some staff and me at times do get slightly nervous that when HMI CFRS return, they will very clearly see that we've prioritised the audit reports. But as far as I'm concerned, I have a very clear rationale around the public accounts and auditing regulations in 2015, and the Audit and Governance Committee's role require that we respond to findings and recommendations in a timely manner. And it's incumbent on me, I think, to make sure that we move through those audit findings as quickly but as thoroughly as possible. And with the capacity that we've got, it's also important that we do so in order to clear that work from the work schedule so that we can then focus on more of the cultural and developmental issues that HMI CFRS want us to focus on. The key point to make there is that quite clearly we don't do these things in isolation. Some of the audit findings are cross over into the HMI CFRS findings and vice versa. And of course, we're continually working on cultural improvement, values and positive behaviours in the organisation anyway. So hopefully when HMI CFRS come back, they will see progress around cultural development. They'll certainly see progress around business fire safety, even in the face of COVID-19 and the fact that we had to suspend physical fire safety inspections. So they moved to desktop audits. Those desktop audits were reinstated back to physical inspections as part of the County Council's reinstatement programme. And we have been carrying those out again, and we've updated our risk assessments on how we re-inspect business premises due to the current lockdown, and that is on an individual case-by-case basis. So with the appropriate training, PPE and safeguards in place, and where the business is still in operation and is happy for us to put staff into those environments, we will continue to carry out business fire safety audits to make sure that the business community is supported and is safe, but also members of the public who use those business premises are safe when doing so as well. Again, that's come as a result of some significant improvements around how we organise ourselves for fire protection, which is obviously a statutory duty. The aim, just to wrap up the improvement board element, we thought that was going to be an 18-month piece of work. So we were aiming for April Audit and Governance Committee to clear those audit actions. Other than a few straggling audit actions that are GCC-wide and are slightly more complex in nature because they're related to culture or behaviours, we are now aiming to wrap up those audit findings and recommendations in the January Audit and Governance Committee of next year. So I'm really pleased to say that we've had an immense amount of support from the Audit Risk and Assurance team. We've also had a lot of support from many other departments across GCC, but it has been a Herculean effort, I think, of staff within GFRS particularly, to work through in a very diligent and a very robust way to work through all those audit recommendations to get to a point where the date this audit report, which you can see, was written, you can see there were 78 implemented actions and 17 in progress out of the 124 and 29 awaiting feedback. I think we're now down to about 11 outstanding that are within the control of GFRS alone, and then others obviously cut across the whole of GCC, as I say. So again, Herculean effort with a lot of support across GCC and also quite a lot of learning more broadly for GCC as well that we're sharing where that's appropriate. You can see then business planning. I think we've covered most of that, other than suffice to say, we've had a cabinet decision authorised some time ago. I think it was since our last scrutiny committee meeting, where cabinet has authorised that we extend our current integrated risk management plan for 1 year, which allows us time to heed some significant programme and project development work that's taking place by the National Fire Chiefs Council about how to conduct effective integrated risk management planning analysis for the future. But importantly, it also allows us to align our integrated risk management plan with the County Council's corporate plan as well, because it was out of step. So we will be looking to we are developing an IRMP, and we'll be looking to get drafts of that both to this committee and to cabinet, obviously, throughout next year, ready for public consultation at the end of next year, to be published in April 2022. Some good news there around community safety. You'll see that we have been supporting South West Ambulance Service. Just draw your attention to the fact that we have started again from the 2nd of November. So 8 days we've been running an ambulance 24/7 for South West Ambulance Service, crewed by a mixture of paramedics and firefighters. There is an option for firefighters only to crew those ambulances if winter pressures get to the point where South West Ambulance Service need to pull paramedics into other vehicles, and fire and rescue service staff can crew those vehicles alone. So really pleased to see that partnership work is continuing. That literally does save lives on a day-to-day basis. And you can see that just through the period that ended on the 31st of August, the Gloucestershire crews responded to almost 750 incidents out of over 5,000 across the southwest, and that was a shorter period of time than we plan to be working to support SWAST from November through to the end of March next year. In relation to quick update on trading standards, coroners and civil protection. So trading standards work has been hampered somewhat by the next lockdown again. We did reinstate all services, but obviously their investigations and interviewing of staff now needs to be amended to take account of the current lockdown. And there is a growing concern that we're keeping a very close eye on in relation to the courts backlog there, because obviously you'll be aware that trading standards prosecute people through the courts. They also recover some of their costs through the Proceeds of Crime Act that comes through the courts. And there's a concern around the backlog in the court service that will impact on their work. But as I say, we're keeping a close eye on that. In terms of coroners, some good news in coroners that you can see there, that we've now managed to secure 3 additional pathologists to support the coroner service. That was always a significant risk to the coroner service because of the way that that work is contracted, if you like. So now we've managed to secure 3 additional pathologists. It reduces some of the risks that we were concerned about in terms of being able to carry out the number of autopsies that are required on an annual basis. And obviously there are still some minor adjustments to the way the coroner service is run as a result of COVID to make sure that they can operate in a COVID secure way. Keep the staff safe, but obviously still be very sensitive and sympathetic to what is quite a significant time of grief for families, friends and loved ones. The civil protection team, you can see there they are in the process of providing support across the range of incidents and events that run currently, but are also reviewing some of our plans with a slight increase in their capacity of late. they can now get through some of the work and start to refresh and review some of the plans that helps us as a county council prepare for and train against foreseeable events or incidents that might occur and affect the communities in Gloucestershire. And happy to take any questions.
Thank you, Wayne. Any questions, members? Someone's putting a hand up here.
See, Jeremy's indicating, Chair.
Jeremy.
Thanks, Chair. I don't know what's happening, but nobody seems to be recognising the hands up thing when we flag it up, which is a helpful way of.
It's not showing, Jeremy.
It's not showing, Jeremy.
No. Oh, it's not showing now. It was. I'm just taking it down. Is it showing now?
No.
Right. Okay. Well, it's obviously
Andrew
not
is also wishing to ask a question.
Yeah. Anyway, I'll go back to Wayne, and it's good to see that what the fire rescue service was doing to help South First Ambulance during the COVID crisis, and that you're now going to continue that work. But I just wonder, what other things have our firefighters been doing to help the general public during the COVID-19 crisis that we've been going through? And also, how well have we been continuing our self and well checks? Because quite clearly there are other hazards that people have to live with, and it would be disappointing to learn that we're not even carrying out checks to make sure people's homes are safe, particularly those that are vulnerable. Well, we do need to provide advice to people about fire hazards or other hazards in their home. I just wonder what the general area of work has been done during this time, during the pandemic.
Thank you for the question. And obviously, we've been exceptionally busy in terms of trying to support the LRF structures and the various cells that have operated beneath the strategic coordination group in support, certainly of both the partners across the LRF, but also colleagues across the county council. I mean, just a quick canter through some of the stuff that fire staff have been involved in. So the mortality cell working with the coroner's office to support the temporary chapel of rest arrangements that were in place. And that included staff both in the management function of that facility, but also in the transportation and the movement of the deceased. And that was, again, a very sensitive but quite significant piece of work that was heavily supported by Fire and Rescue Service staff. So also, we've been working with partners to create safe working environments for certain partner agencies, so opening up GFROS sites to allow them to work from, so police neighbourhood teams working from Skill Zone, adult social services from both Cheltenham stations. Staff have been involved in the management and logistics of the distribution of personal protective equipment, the delivery of food parcels to the vulnerable, PPE into care settings. They've also been undertaking respiratory face fit testing for respiratory protection for care staff, infection prevention and control training as well in support of NHS and public health team staff to just put some additional capacity, how to wear PPE effectively and prevent infection transmission, and providing refresher training to people. They've also been supporting the NHS by the logistics and the transport effectively to take outreach swabbing to care homes and other hard to reach people, and then waiting whilst those swab test kits were used and delivering them straight to laboratory testing facilities to get the turnaround as quickly as possible. We've worked with the NHS and local GP surgeries to facilitate a drive-through or drop-in flu clinics at various stations fire stations around the county. Where we've got the COVID testing stations as well, we've worked alongside the police and the military to set up and run the various mobile COVID test units deployed across the county. And then track and trace welfare. So a team's been established to support the public health team in the track and trace effort to provide what we're calling a boots on the ground resource. So where we struggled to contact people through the normal contact tracing arrangements, it was found, learning from other areas, particularly Leicester and Swindon, it was found beneficial to actually get people out and knock on doors to chase down those people who we were finding it hard to contact trace. So again, we've been able to mobilise staff to support that. And then we've got an officer who also sits on the Mass Vaccination Command Group that's looking at the programme of vaccinations once the vaccine is available. And again, that could be around consumables, delivery, storage, and the walkthrough or the offer of facilities to support the delivery of that. So as you can see, and that's in addition to the work we've been doing with the ambulance service, so quite busy, spread across a range of activities. We've, in terms of safe and well question, Jeremy, we did continue to deliver safe and wells to the very high risk category. We did have to pause the safe and wells across the lower risk categories, but we did carry out an individual risk assessment on each request or referral for a safe and well visit. And we continued to deliver COVID secure safe and well visits to the very high category. And what we've seen in our performance is that there's been an increase in the number of very high risk safe and well visits undertaken against the backdrop of a general decrease in the total number delivered. So you'll be aware through HMICFRS last year that a backlog was identified in the number of safe and wells carried out against the referrals received. We'd managed to completely eradicate the backlog, but unfortunately that has increased again, only very slightly. And we have got additional staff in place to be able to sort out the backlog and address the targeting of future safe and well visits. So I think it's something that we've altered our response to. We've introduced a virtual way of delivering safe and well visits, but we are still targeting the very high risk.
Thank you.
Thank you, Chair. That shows that's a really good global report. It just shows the great work that our fire and rescue service does in Gloucestershire.
Yeah.
When we've been with a pandemic and a crisis, they've gone the extra mile and done a lot of extra bits of work to assist everybody else. I think that's encouraging. That we should probably have a fuller report at the end of when we move out of the pandemic, just a report back, and for history's purposes, if nothing else, what the fire and rescue service has done in Gloucestershire during this time. That's encouraging to see the work you've been doing, and you've still managed to do it is a high risk individuals that were places we need to carry on doing the self and well checks, because those are the ones that are in danger of having a house fire or other accidents. We need to make sure that we're still keeping an eye on them and giving them proper advice, making sure homes are safe to live in, not just COVID safe.
Okay, thank you, Jeremy. Andrew?
Thank you, Chair. I'm really happy to follow on from Jeremy's comments there, and I'm sure that all the committee would go along with those comments. I hope that the Chief will find a way of, when he next communicates with his teams, to tell them that the committee this afternoon, welcomed the work they're doing and highlighted this area. And also, again, I want to refer to the joint working with SWAST, with the ambulance service. Gloucestershire HOSC was instrumental in setting up the Inter-Authority Scrutiny Committee, which looked at the performance of the South West Ambulance Service and its predecessor. And I chaired that committee for a few years and learnt a lot about the ambulance service and about joint working. So Wayne, I hope you are able, please, to find a way when you next talk to your colleagues, whether by meeting them or in emails, to say that this committee welcomes their work, the work that Councillor Hilton just highlighted, and also the joint working with SWAS, because there's no doubt about it, your teams are saving lives every week, and we should recognise that and be very proud of that and thank them for their work.
Thank you. Thank you.
Thank you for those comments.
Sean, you've got your electronic hand up.
Yes, I did. I really want to go back to a comment which actually came up in the audit and governance, which I raised, which is the cultural change, which I think is underway. And basically, which obviously is going to take quite a lot of time, and the closer integration of the fire service with, in fact, the county council and the county council's standards, which we have. I'd be interested for a comment. There's a lengthy discussion on this at audit and governance. And also, is there anything which really we as councillors should be doing to help that that integration more? I think it's underlying the whole of this thing was the need for the fire service to become more fully, I think, integrated with the county council. And of course, we've had lots of evidence of that, which have just demonstrated. I mean, it's a tremendous job you're doing. But anyhow, I'll leave Wayne to make a comment on that.
Thank you, Sean. I think in terms of the support that members can give, I think the change in scrutiny is welcome, and the fact that there is a greater degree of scrutiny now being applied. And in fact, as well, to support that, yesterday we had our first finance, performance and risk meeting for community safety alone. It used to be as part of economy, environment and infrastructure. So I think as an authority, Gloucestershire has demonstrated its seriousness and commitment to apply a greater degree of scrutiny to what the Community Safety Directorate is doing, and that's welcome. And I think with Councillor Norman's support, I think members at present are doing what we need you to do, to, by showing your support, but also being very clear about the expectations you have about integration and about the type of fire and rescue service particularly, and the way it conducts itself that you want for the people of Gloucestershire. And I think, we share that passion and that commitment, and it's just useful for me to know that we've got that support and that degree of scrutiny is being applied. I think the cultural journey that you've referenced, it is difficult. It's difficult to measure. We are, I believe, and it is subjective, but I do believe we're starting to see movement and progress with some of that. Not that we want complaints anyway, but generally they either go through the whistleblowing policy or straight to the media, and we are seeing an increase in some of them coming through line management, which is a positive step. That demonstrates that there is some degree of trust being rebuilt within the service. And then, we're out recruiting at the moment for new whole-time firefighters. That positive action has started at the minute, and we'll be looking to bring new firefighters in the first half of next year. And there's a clear and strong focus on values and behaviours around that recruitment process. We can train skills, we can't train values and behaviours as well, or as easily. So we're making sure that new staff into the organisation are brought in with the right values and skill set. But we're also focusing really, really clearly on the standards and expectations that I have to say 99% of the organisation actually do have and demonstrate and uphold and want to be known for. So I think we're in good shape. We're starting to show green shoots, but it is a longer journey. In terms of one of the previous questions and comments, one of the reasons that I didn't bring a more detailed report about what we'd done through COVID, for example, was because I'm waiting for the HMICFRS inspection that's taking place this week for the report from that. And then we can bring that forward to a future meeting. But again, hopefully that will make some references to the culture within the organisation and how staff have stepped up.
Thank you very much.
Fine. Yeah, that's good. That's good.
Thank you very much.
No more questions, Member of Wayne? Fire and rescue are quickly becoming very, very highly regarded nationally as the place to work, which is a good change, isn't it? A good change, Wayne. And thank your team for all the efforts they're doing during this current difficult time. Thank you.
Thank you.
We now move on, a quick dash now, to the Q2 reporting systems. Can I just ask people just to talk to certain important areas and don't, where there is a symbol which shows that there's some work to be done. So if we want to start at Kathy and Carol, what areas of concern have you got in the performance report?
Hello. I think the areas of concern that we have obviously is about the increased demand on our service and the amount of money that perhaps that we need to commit that. And I think at the moment, I think after the year that we've had, I think we have to look at this report in a bigger way than we normally would do, I think. I think overall our services have run really well. And we've learned an awful lot what's gone on, and our officers have been working under an extreme pressure all round. I don't really want to pick on any particular ones, but overall we have discussed it briefly with Margaret only last week, and we do feel that the report isn't a bad report, but there are areas of concern. But that is partly because of the situation we are in at the moment with COVID. COVID has actually put on an increased amount of pressure and expenditure on the department. And no matter how much money gets thrown at it, there will always be areas where we're going to have to keep very close eye on what we're spending. Maybe Carol would like to just come in on that one.
Thank you, Kath. I think for me the report is fairly simplistic, and it gives a hint of the amount of effort and work that officers and other sectors are putting into the care of our most vulnerable people. I think some of the learning that we've taken from COVID will inform future reports. But we're monitoring it very closely. We're having weekly meetings, and our interventions will be to safeguard what we've got and to grow our services really, but make them more effective. Margaret's alluded to a whole cultural shift from actually maintaining people at home for longer in a better circumstance. That's a significant cultural shift, not only for the county council, but also for families and indeed individuals and our partner agencies. So there's an awful lot of work going on. We're monitoring it on a weekly basis. And I think we just bring reports to you and expect scrutiny. Thank you.
Thank you. Yep. Thank you. We now move on to Tim, Prevention, Wellbeing and Communities. Tim.
I just make slightly similar comments with regard to staffing, but I mean, with regard to the performance across public health, I think I'd say two things. First of all, we're still going through this crisis. We're nowhere near the end. We may not even be near the middle yet. We don't know. So there's part of me that feels that the indicators aren't yet really collecting enough data that's up to date to give us a true picture, but there's some indications that they might be slightly better than we might expect given all the pressures. I think we'll have to continue to watch that one, but quite clearly there are major pressures on people this time. I'd go back to something Councillor Dobie said earlier on, which is relevant on the mental health. I mean, I do agree about the publicity and about the making people aware of the services that are there, the additional services on top of the ones we've had before in this area. And at my request, the district councils have been asked if they would agree to put links to their websites to our services. I think they have agreed to do it in most cases. And that is a way that, if you log on to, let's say, Cheltenham Borough Council's or Tewkesbury Borough Council's website, that you would see another route into knowing what those services are. I understand those services have had a good uptake, but there is still some capacity. And I think this is a time when we'd like to see that capacity fully used. And I will be doing all I can looking ahead, to make sure we continue, because as I said, this isn't over yet. And in the sense, even when it is over, I suspect it'll be quite a long time before we get back to anything like normal. Whatever normal looks like. Thank you.
Thank you, Tim. And then we come on to public protection of parking and libraries. Dave, are you about?
I've been here for the whole of the meeting, Chair, and
you've been very quiet.
I've listened intently. I haven't had my camera on because we've got problems with bugs in respect of the face keeps disappearing. But
Right.
as the chief alerted committee this morning very much to the points that are highlighted before you today in the trend analysis, I think he clearly explained the situation in respect of safe and well visits. But it's really positive to see that we are targeting those who are at most risk, which is, I think, what we would expect at this time when we couldn't continue to go out to as many that we would like to, and from the more general public situation. Also good to see that the issues around accidental dwelling fires and response times is positive in the way that we should be going. The fire and rescue service continues to deliver a service above and beyond, and it's very nice to hear some of the comments that were made to the chief earlier on, and I obviously, as the cabinet member, feel that the way the service is going is moving at a pace from a very difficult starting point. The journey has been challenging. We will continue to deliver a service that is cost effective and efficient and does all that it can for the residents of Gloucestershire. So I believe it's positive, Chair.
There is variable cloud, a few clear spells, so it'll be a little bit chillier further east.
I think we've got some background noise. Can everybody just make sure they're muted, please?
Someone's got the news on. Okay. Thank you. Do we have any questions, members of the performance reports? No? Thank you. We then, last item, the work plan. Joe, do you want to have a quick run through the work plan?
The only additional item that we've got today that came through the meeting was just to review the recommendations that Sarah mentioned earlier in her presentation with the annual report, which was the how the recommendations for ethnicity, I can't say the word, but basically the recommendations that we said earlier in the meeting, BME, ME, and how we take those forward. So that'll be on the plan for in a 6-month review. I don't know if you want to mention, Chairman, about the proposal to have a joint meeting in January. Do you want to take that forward?
Yes, and we wish to have a joint meeting of this committee and the HOS committee. Is it the 24th of January? Yes, the 24th of January. 26th of January, where we can explore common requirements and common interests. So the 26th of January will be a joint meeting with HOS. Okay.
There will be an opportunity for the directors to present, to look at responses to COVID, to really look at some key issues. There'll be a short presentation from each of the directorates, and then HOSC members and the members of this committee will be invited to ask questions. I think it will just be an opportunity, hopefully in January, to review where we're at and where we're going. So I think that's the proposal. And I think, Chairman, did you want to just mention about the presentation, the mental health presentation on the 20th, children's mental health briefing on the 20th of November that all members of this committee are invited to?
Yes, Friday the 20th, we have the Children's and Young People's presentation briefing, which should in fact complete our quality circle. So that's the 20th of November, Friday, 2 o'clock till 4 o'clock in the afternoon. Okay, Margaret.
Yes, yes, Chair. Just to remind the committee that for the January joint meeting, I will no longer be the DAS because I'll have stood down for Sarah. I'll still be here till the end of March, but I won't be at them. I won't be a statutory officer, so I assume I won't be at the meeting. I could creep in and observe. Whether I can stay quiet is the problem.
Well, Margaret, how many years?
45
years. That's fantastic, isn't it?
Yeah, be 45 and a half when I go. So,
right.
Pretty good, isn't it? I've got 3 extra little bits of information that have come in since we've been in the meeting, if you want me just to update something I said earlier. Okay, so number 1, demand on dom care has tripled in the last 28 days, not doubled. I got that wrong.
Tripled.
Tripled, so it's gone up 3 times in 28 days. The demand for patient beds for COVID in the hospital, Deb Lee has just told me, is doubling every 6 days. So she anticipates by the end of next week there being 160 COVID patients in the acute. That's where her estimation is. And then, just to upset Jeremy even more, I've just been told that the Department of Health, no, not the Department of Health, the Department of Health and Social Care have just told me in a confidential email that NHS England is sending a letter out to all directors of adult social care this afternoon, instructing us to use care homes for COVID positive patients.
OMG.
So I'm determined to resist it, but I'm just letting you know that we're being given a straight direction now. I don't know where my statutory powers allow me to deny that, but I'll be talking to my health colleagues tomorrow so we can make a collective decision.
I think, Margaret, you're at the time in your service that you can take as many risks as you want.
Yeah, I know I am getting a bit feisty in my old age, and I think it is because I can see that little dot over there that says, actually, by the time we find out about this, you'll be gone, so it'll be okay to be naughty.
Yes, indeed. Margaret, we have valued every minute of your time.
Well, you're very welcome. I've valued yours as well. Even the difficult ones we've learned something from, haven't we?
Yeah.
Yes, indeed we have. Sorry?
Stephen, can I just butt in? Margaret mentioned about, of being upset by the NHS instructing the use of care homes. When you were talking earlier on, you made it clear that these care homes would have to have separate units, have dedicated staff and proper PPE and separate access points. Could you provide a short briefing to members of this committee exactly what those regulations will be? Because that will certainly remove quite a number of care homes, quite clearly the ones that you say are having trouble with infection control. That will remove quite a number of care homes from the list that the NHS could impose on. It would be useful to know what the regulations are. Thank you.
Yes, absolutely. Of course I can. I think the other issue is as well that they have one of the other regulations or one of the other standards is that they have to be above the line. They have to be good or excellent. They can't be a failing home. And so any home that's in difficulties won't be passed by CQC. And I think I said earlier, nearly half the homes they've inspected across the country so far have failed the inspection, so they don't qualify to be a COVID positive home. And that tells you quite a lot. Regardless of whether they've got 2 front doors or, well, obviously not 2 front doors, 1 front door, 1 back door, or a conservatory or whatever that can be isolated. The big issue for them is the staffing, because it's actually very difficult to keep the staffing that tight. And we know that some of our nursing homes that are in the bigger companies, they're so short of nurses that the nurses work in more than 1 home.
Yep.
And of course, the government has just issued some instructions saying that you're not allowed to do that. So the legislation is rolling out on almost an hourly basis. But as I said before, my personal view is that somebody hasn't thought this through properly. So I will resist it at all costs. But if we have to concede, then I'll come back to you and let you know which homes. My guess would be that I might be wrong, but I'd be very surprised if any homes wanted to do it.
Okay.
Thank you.
So it'd be useful to have that information anyway, Stephen, just to,
Yes,
so
it
we've got a briefing so we know exactly. If people ask us, we can be reassure maybe some that it's not going to happen.
Yes.
But, okay. Thank you.
Thank you very much, members. A very useful morning. We've all learnt a lot. Sorry, Ian, you're waving, or is it just purely goodbye?
Not goodbye. You were asking about the work plan. I had a suggestion for the work plan.
Yes.
So I note that the Gloucestershire Suicide Prevention Strategy is due to be revisited shortly. Please, could we bring it to this Scrutiny Committee for consideration?
Yes, indeed.
And secondly, I note that we're planning in a few months ahead for there to be a joint meeting of this committee and also the Health Scrutiny Committee. The decision to split the health and social care, I never agreed with, as you know, and it was due to be reconsidered after a period of time. I had thought that that period of time was due to be up by the end of this year, so that we could perhaps get back to a COSC as we used to have in the old days.
Democracy is all, isn't it? Democracy is all.
So when, and I'm asking Joe this perhaps, when will, as promised, that decision be formally reconsidered?
We are working on.
I can answer that. I've been discussing this already with Simon Harper. I'm not quite certain which meeting we're bringing it back to, but it is something which is on the agenda for the Overview Scrutiny Committee to look at.
Excellent. Thank you very much, Sean.
Okay, members, thank you very much for the morning. See you around.